Is it time?
1 minute.
1 minute.
Very
good evening to one and all of you for our ARC webinar on ocular trauma this time. And with the best of expert panel and a great set of speakers, I'm sure we are all going to be glued on to this webinar for the next 2.5 hours. We are truly lucky to have with us on the expert panel our Padma Shri, Dr. Grover, who's not only the past president of AIOS, but also the chairman of the Department of Ophthalmology of Sri Gangaram Hospital and his Vision Eye Center, New Delhi. Joining us soon is going to be Dr. Purendra Bhasin, who's the founder and director of Ratan Jyoti Netralaya Ophthalmic Institute and Research Center from Gwalior, a very prolific surgeon. We are truly lucky to have him with us. Dr. Natarajan, who again is our past president and also the past president of AIOS and also the head and consultant of Vitreous Retina Surgery Department at the Agarwal Eye Hospitals, Mumbai. We are truly lucky to have Dr. Natarajan, and I'm sure he has been one of those leaders to have evolved this Ocular Trauma Society. We have with us Dr. J.K. Parihar, who's again a veteran, prolific, amazing surgeon, and he's with years of experience ahead of him and is now oculoplasty head at the Center for Sight Group of Hospitals based at Delhi. We are truly lucky to have with us a very dynamic Dr. Santosh Honavar, who currently heads the Department of Ophthalmology and Facial Plastic Surgery, Orbit and Ocular Oncology at the Center for Sight Group of Hospitals in Hyderabad. And we all know that he has taken us to a different level with his amazing work done at AIOS, and I think he has beaten the best, and we have yet to look at something which could better him. And thanks a lot, Dr. Santosh, for all your contributions to AIOS. We have with us Dr. Mehul Shah, another very pleasant, quiet, but a very dignified gentleman and the medical director of Rashtriya Netralaya, and who has done wonders with Dr. Shreya Shah towards upbringing of this center and all the surrounds and keeping them all wrapped up under his charm. Moderating with me is Dr. Shreya Shah, who's a pediatric ophthalmologist and oculoplasty surgeon, again from the Rashtriya Netralaya. And I wonder where to put her in. Put her in oculoplasty, cataract, refractive, name it, she does it. And I'm sure over the course of the meeting, we would understand even better how amazingly she's going to be moderating this whole session. We shall go on to our first speaker, Dr. Sujitra, who again is a clinical additional professor of the Department of Ophthalmology from Amrita Institute of Medical Sciences, Kochi, and she is going to take us on to a very important topic, traumatic optic neuropathy. On to you, Dr. Sujitra. Can you share your screen?
Yes, ma'am. Okay, is my slide visible, and am I audible?
Yeah, both.
Yes.
Oh, thank you. Good evening. Thank you, Chitra ma'am, for this opportunity. And I'm moving on to my topic, traumatic optic neuropathy. And it is a very difficult topic. And I'll go through 2-3 cases which I come across, then to the topic. Okay, first case, it's a 28-year-old male. He presented with loss of vision in right eye following RTA. There was vision at presentation was doubtful PL, and there was proptosis and restriction of all ocular movements, and his left eye was normal, and CT scan showed fracture of orbital wall, that is medial wall, lateral wall, and floor, and there was hematoma in the orbit and hemosynus on the right side. So IV methylprednisolone was given for 3 days, then oral steroid was started, and immediately we did cannulisis and evacuation of orbital blood, and his proptosis improved but vision did not improve. And the second case is a 57-year-old male presented with decrease in vision in right eye following RTA. He reported 4 days after RTA, and his vision at presentation was 6/60, and there was RAPD, color vision was defective, left eye was normal, fundus also was normal, and in CT scan, report was normal. There was no intracranial bleeding, but since there was RAPD and vision decrease in vision, we did MDCT with 1 mm cut, which showed fracture of lateral bolus phenol sinus with mild indentation of the optic nerve. And IV methylprednisolone was given, and for 5 days. Then he was started on oral steroids on tapering dose. His vision improved, and visual field also improved. Color vision was partially defective. And 27-year-old lady presented with loss of vision in right eye, and there was RAPD, and CT scan showed right orbit and orbit fracture and hemosinus, and she was given intravenous methylprednisolone, and orbital decompression was done, and her vision improved, and there was improvement in visual field also that we can see in this picture. So when I analyzed retrospectively the cases which I saw in our department, the younger age group is more commonly affected, and males are more commonly affected. 91% of the patients are males, and our most common cause is road traffic accident, and indirect traumatic optic neuropathy is more common when compared to direct injury. And most of the cases are associated with orbital fractures, and lateral wall fracture is more commonly affected with associated with optic nerve injury. And coming to treatment part, 24 patients received intravenous steroid therapy, and 5 patients received surgical treatment, and 5 patients were managed conservatively. And we saw that patients presented with poor visual acuity had poor final visual outcome, and lateral wall fracture was the most common fracture associated with indirect traumatic optic neuropathy with a poor visual outcome. Coming to the topic traumatic optic neuropathy, there are 2 mechanisms, direct and indirect. In indirect traumatic optic neuropathy is the most common form of traumatic optic neuropathy. The blunt head trauma, usually to the forehead, produces a deceleration injury, and which leads to sharing of the nutrient bile vessels, leading to optic nerve injury. Another mechanism is force of impact on the forehead is propagated and focused at the orbital apex in the area of optic canal as a shock wave, producing optic nerve damage. Direct optic nerve injury can occur from a compression by a bony fragment, or it can occur due to orbital compartment syndrome due to active hemorrhage in the orbit. It is an ophthalmic emergency which requires immediate management. Direct optic nerve injury can also occur due to penetrating injury or transection of optic nerve fibers, or compression from hemorrhage, edema, or impingement on the nerve by a foreign body. Optic nerve head avulsion is also a rare injury. It presents with profound visual loss. A rare cause of direct optic nerve injury is optic nerve sheath hematoma. Here the presentation is there is progressive visual loss. Initially, it decreases slowly. So this is a classical finding of optic nerve sheath hematoma. Coming to presenting features, most common symptom is vision loss or defective vision, depending on the severity of injury. Again, coming to clinical signs, most of the time we won't be able to record visual acuity since the patient is under trauma. Sometimes they may be not oriented or not conscious enough. We have to depend on our pupillary examination. So RAPD or sluggish pupillary reflex would be the key finding to suspect optic nerve injury. And also the history part and also the severity of injury, there have been involvement of optic nerve. So we have to be very careful in assessing pupillary reflex here, because we won't be able to assess visual acuity, color vision like that. And in acute stage, the fundus examination also will be normal. And coming to evaluation part, so whenever we see a head trauma, we should do imaging CT scan. That too we have to do if we suspect optic nerve injury or optic canal involvement, we have to do MDCT with 1 mm cut to look for any small fracture imaging on optic nerve. And if we suspect hematoma, it is better to include MRI also. If there is no contraindication for MRI, like any metallic foreign bodies. Otherwise, it is better to do CT and MRI combined. Coming to treatment part of it, still there is no definite treatment for traumatic optic nerve injury. There are various studies which supports giving intravenous methylprednisolone. Some studies are against, and some studies they say that the outcome is good even with treatment or without treatment. But one definite evidence is if there is severe brain injury, we should not give intravenous methylprednisolone, as it causes the mortality rate is more in patients who received intravenous methylprednisolone when there is severe brain injury. Due to paucity of time, I am going very fast. And this orbital compartment syndrome is a definite indication for urgent surgical decompression. If there is severe hemorrhage with a tight orbit, we should do immediately, we should do cambolysis and release the orbital pressure and evacuate the blood clot. That will save vision. That's all. Thank you. And to conclude, the prevention is better. So we have to create awareness about safe driving so that we can avoid traumatic optic injury, head injury, because most of these people involved here are young males. Thank you. Thank you so much. Thank you, ARC, for giving this opportunity. Thank you, Chitra.
Thank you. Thank you for a very crisp and very nice way of taking it on with examples. And it was a very gripping talk. Thanks a lot. I just thought I'll take a question or two, and Dr. Shreya would also take. And Mr. Sunil, you will have to keep a watch on the time. Of course, this talk was very much within time. Please, Mr. Sunil, be connected so that 7th minute you give us a warning.
Sure.
And the one question is, how rarely or how often would any of you think of doing an optic canal decompression? Because I think it is something which can be done if it is within 24 hours of the injury, right?
Yes, ma'am. Yes. Nowadays, we have endoscopic assisted surgery we can do. If the presenting visual acuity is better, then outcome also would be better. And if the presenting visual acuity is no PL, then again the chances of visual recovery is less. Still, we can do optic canal decompression if there is bone fragments or hematoma in the optic nerve.
Yeah,
There is one patient I showed where there was improvement in visual acuity. In another patient, though there is bone fragment impinging and there is blood collection in the sphenoid sinus and the medial wall of sphenoid sinus impinging on the optic nerve, he improved with methylprednisolone alone. So still there is no definite way that this is the treatment.
Which kind of ocular trauma,
Understood.
Dr. Grover, when would you refer them to a neurosurgeon and not treat the eye as a first instance?
So, Chitra, foremost, there are very few indications for intervention because there are no multicentric large studies or controlled studies, of course, are even more difficult. There was an attempt at a multinational, multicentric study which could not muster enough cases, so it was abandoned. That was about a decade ago. So there is no conclusive evidence to say that decompression fares better than IV pulse steroid therapy. And only if you have a definite bony fracture seen impinging on the optic nerve that you think of a decompression. Most of the times we are able to, if there is a sphenoid fracture which is causing it, we are able to get our ENT surgeons to work endoscopically to take care of that. Very rarely is a neurosurgical intervention needed. And an endoscopic navigation guided intervention can also be done through the orbital approach, which Kasturi has done a few and she's been happy with the results. But on the whole, the indications for surgical intervention remain very limited. And most often you would go by IV methylprednisolone, except if there is a compressive optic neuropathy, which Dr. Sujitra showed so well, where there is a clear-cut indication for decompression.
Dr. Shreya, can you unmute yourself? You're muted.
Thank you, Dr. Chitra, for allowing me in this presentation. Most of my questions are already answered by Dr. Grover sir, but I would still ask Dr. Grover sir that what are the different surgical modalities would you prefer for different kinds of traumatic optic neuropathy, and exactly at what time would you like to intervene? As already some of the questions answered. Am I audible?
Yes, you are audible.
So if you are to intervene, you have to intervene early as possible. And especially in cases where the visual acuity is poor, you would have a greater threshold for intervention. In others, you would probably go with IV methylprednisolone only. And those supra doses which were earlier talked about in spinal injuries have now been abandoned. Very, very high doses which were earlier being used in spinal injuries were also tried in orbital injuries. Those are almost given up now because of higher mortality. So intervention, if it is to be done, is either a transsphenoid approach, if sphenoid bone is involved with the involvement of the ENT surgeon, endoscopic ENT surgeon. Sometimes a neurosurgeon, when you find that they cannot approach and it is a very close to the orbital apex. But at other times, you have a fragment on the medial side, which is impinging, and you can go in from the orbit as well. So all three approaches are possible, and depending on which bone is seen to be impinging on the optic nerve. But these will be very few cases. Most of them would be treated conservatively.
Thank you.
Thank you. Okay. We shall now go on to our next speaker. Thanks a lot, Dr. Suchitra. Do stay with us and add to your thoughts. We shall now go on to Dr. Mayuri Kamar, who's again a senior glaucoma consultant and a very prestigious person in the Glaucoma Society of India, who's practicing in Ocular Eye Care and Research Center at Ahmedabad. And she's going to talk to us on a very important topic, trauma and high intraocular pressure. On to you.
Thank you, Chitra, for giving me this opportunity. I will be talking on trauma and high intraocular pressure. I will start with a case of mine, 59-year-old male, complaining of gradual diminution of vision and floaters in the left eye since 6 months. Already diagnosed to have glaucoma since 9 years in the left eye and currently on brimonidine BID dose. Systemically well-controlled diabetes and no family history or no refractive error on any previous eye tests. This is the slit lamp picture of the left eye showing you the sphincter, small sphincter tear at 6 o'clock. And the vision, both eye corrected was 6969. Right eye was absolutely normal and intraocular pressure in the left eye was 23 millimeter of mercury on brimonidine. And pachymetry cornea was within normal range. The gonioscopy we did, and it was found that the angle recession was seen in a left eye on 3 quadrants, and there was also a black ball sign, and the AIOS OCT has also shown the confirmed the finding of the angle recession in the left eye. The left eye visual field was also correlating with the advanced disc damage, and right eye was normal. So what we have in this case is a unilateral advanced case of glaucoma. Slit lamp showed us the sphincter tear. So there was a suspicion of a trauma to that eye, and gonioscopically also the AR and the black ball sign confirmed our suspicion. So we again took the detailed history, and there was a ball injury in early childhood, which he was almost forgot. So the diagnosis of left eye traumatic glaucoma was made, and then the treatment was enhanced and he was well under control after 1 year. So the message here is the rise in intraocular pressure, high IOP following the trauma could be early phase or in the late phase. In early, usually it follows the closed globe injury, rarely the penetrating trauma, and the late, usually it is unilateral, follows the closed globe injury and may follow the open globe injury. Most commonly, they have an open angle glaucoma, and very less common or rarely the patient may have a closed angle or pupillary block. Various mechanisms are involved when you have a high IOP following the trauma. When in early case with a blunt trauma, you should suspect if the associated findings are like circumciliary congestion with the hyphema, or iris trauma like iridodialysis, or subluxated lens, or some lens trauma, or when you have a corneal haze, typical corneal haze, which could be there with a chemical injury, but also it could be sign of raised intraocular pressure. In the late cases, we should suspect it when it is unilateral, can have a corneal scar or abnormal iris scar or the patterns. And lens-induced glaucoma, see, I can't go into the details of each and every secondary glaucoma that can happen following the trauma, but lens-induced mechanism could be focal lenticular opacity, or phacodonesis, or phacomorphic or phacolytic glaucoma. The patient can have a diminution of vision because of the vitreous hemorrhage, which can lead to the ghost cell glaucoma, or it could be an old retinal detachment. And sometimes you may not see any obvious cause. Now, there are some key points which helps us in differential diagnosis of various mechanisms. Like in early onset, you have a history of contusion injury, trabecular meshwork damage, or traumatic hyphema or chemical injury. In late onset glaucoma, it could be angle recession, ghost cell glaucoma, lens-induced glaucoma, peripheral angiosynecia, or closure of the cyclodialysis cleft. Sometimes patient may have a retained intraocular foreign body or choroidal hemorrhage and retinal detachment. Now, how do I do my diagnostic workup in this particular case? Usually, history is very important. It could be, always ask whether it is a blunt trauma or the penetrating, and look at the severity of the disease. Also, it is important how much is the intraocular pressure, how bad it is, and always rule out the possibility of intraocular foreign body. Then the management is different. An interval between the injury and the raised intraocular pressure, what is it? If it is delayed, then it could be an angle recession, or if it is immediate or acute onset, could be hyphema, lens damage, and trabeculitis or trabecular damage. Visual acuity is very, very important in deciding how fast you should act. And particularly when you are talking about trauma, it could be a medical legal case. So visual acuity has to be noted before you intervene. Then evidence of trauma should be seen in all parts of eye. Conjunctiva or the cornea can have a laceration or perforation or blood staining, which is very important sign. And then anterior chamber could have hyphema or inflammatory material, whether it is shallow or deep, depending upon the subluxation or the dislocation of lens. And the alter color RBCs or red brown color RBCs are the sign of hemolytic glaucoma. And the iridodialysis or the sphincter trauma could also help us in a diagnosis. Then pupil could be irregular, or anterior or posterior synechiae could be there. And the lens can have a various findings. It could be, the most common is the pigments on the anterior surface of the capsule. Ruptured capsule could be there, or subluxation or phacodonosis. And if it could be a phacolytic glaucoma, patient can have a lens anterior capsule which has a shrivel or the creases on it and the white spots. The vitreous has to be seen in the details. It could be prolapsing from the zonular dialysis area, or tobacco dust sign is one of the sign of the retinal detachment, and rule out the foreign body in the vitreous cavity, and the bloods in the vitreous can cause the hemolytic glaucoma. And these are various causes or mechanisms that can be there associated with the lens-induced glaucoma. Anterior dislocation cause pupillary block, and posterior subluxation or dislocation allows the vitreous to prolapse through that particular area. And as I said, phacolytic glaucoma is very common, where the leakage of protein through the intact lens capsule causing the glaucoma due to the trabecular meshwork occlusion with the inflammatory cells and the proteinous material. Now, this is a classic example. Post-traumatic glaucoma, sphincter tear, angle recession, black ball sign in a unilateral late onset glaucoma. The angle recession usually seen as a irregularly wide ciliary body band. Retroplacement of the iris root is seen here, and the black ball sign is a sign of the previous hyphema. Always and always compare both eyes angle to rule out whether it is a deep grade 4 angle or it's angle recession. And imaging can be of help if you have a hyphema which is not allowing you to see inside. And UBM identified the ciliary body collapse or the angle recession. And one may use CT or MRI in the difficult cases to find out intraocular fragment. So can we predict the occurrence of glaucoma after closed globe injury? This is a beautiful research study published by Ciota et al. And they have taken the clinical and UBM features of the patient, and they concluded that if there is an increase in the pigmentation of the angle, or baseline IOP is high, or a hyphema or lens displacement and angle recession more than 180 degree, then it is possible that these patients are at high risk of developing late onset glaucoma. Management is aim is to treat the mainly underlying mechanism leading to the increase in the IOP. It's a stepwise management. So first start with the topical medication, and the first line of preferred agents are topical beta.
Time is up.
Time is off. Okay.
Please
Right. When should you have a surgery done? If the pressure is more than 60 millimeter of mercury for 2 days, more than 50 millimeter of mercury for 5 days, or more than 35 millimeter of mercury for 7 days. In that case, you should take the patient in OR and do the corrections. So these are the treatment options that is available. So in short, trauma management of post-traumatic glaucoma is aimed mainly at the main underlying mechanism leading to increased IOP. Detailed history will help you in deciding the differential diagnosis, and surgical interventions are needed when IOP is not controlled with the maximum tolerated therapy. Thank you.
Thank you very much, Dr. Mayuri. That was a very detailed talk and just covered everything. Most of the questions have been answered. But it just in the passing, is there a role of doing GAT in traumatic glaucoma once the inflammation is treated and subsides?
That is done with the primary glaucomas rather than in a traumatic glaucoma where the whole angle structure is damaged. The intercanalicular spaces are also scarred. So maybe GAT is not going to work in this particular case. Still, we are new with that and no studies have shown that it is effective. But the laser that was one slide that I just moved forward. That laser trabeculoplasty is also of not help in this traumatic glaucoma.
Dr. Shreya?
Yeah, I would like to ask a question to ma'am. What are the management strategy after open globe injury? Whenever you have glaucoma after open globe injury, what will be the management strategy for you?
Could be a multi-specialty approach. First, you have to close the globe, manage if there is lens trauma, you have to manage the lens in that particular case, and the multiple factors are involved. In open globe injury, usually glaucoma is not taken as a first line of treatment, only medical management.
Yes, yes. Very
And
true.
Dr. Mehul sir, would you like to take up this question? How will you manage the glaucoma following open globe injury? Dr. Mehul? How will you manage the glaucoma following open globe injury?
Glaucoma in open globe injury can occur at later stage following repair and following cataract management or following vitrectomy. There can be some intractable glaucoma which can be tackled either by micropulse laser or some of the GDD implant, because those glaucomas are very much intractable, or maybe for following the silicone oil injection. So those glaucoma need to be tackled using the non-conventional approaches.
Open globe injury glaucomas, later on when it happens, the scarring is also an issue. So simple trabeculectomy usually is not long lasting. And let's say tubes and valves are better in this option.
Right.
Any other question expert panel have which need to be covered before we go on to our next speaker? Okay. Dr. Ashish, are you, is your laptop working? Dr. Ashish was there with us. Dr. Ashish? I think there is some laptop.
I'll call him. Yeah.
Yeah, we
By
would
the time we can take next.
the interim, Dr. Preeti, are you there?
Yes, I'm there.
Preeti, then we shall go on to you. We have Dr. Preeti Uday, again, a very amazing oculoplasty surgeon and practicing at Chennai in the DRR Eye Care and Oculoplasty Center. And she's going to take us on to a very relevant topic, orbital fractures and ocular trauma.
Good evening to all of you, and thanks for this wonderful opportunity. I've been asked to talk.
All of you mute yourself while Dr. Preeti takes her talk. Yeah.
Thank you. So I've been asked to talk on orbital trauma, and I thought in this next 8 minutes, I will take you through my journey since 2004 in orbital trauma and what has changed since then. So in the past, we used to see a lot of patients with this kind of a scar right in the middle of the face, where infraorbital incisions were taken to place the orbital floor implants. Now we have moved virtually to conjunctival incisions, lid crease incisions, and vestibular incisions. So the patients virtually have no external scars in spite of very complex orbital reconstructions. We have now moved more from MedPort to titanium. MedPort has its role in smaller fractures where we have enough support surrounding the fracture. But most of the time for complex fractures, titanium is the implant of choice. And in earlier years, whenever there was an expansion of the orbital volume, we just filled the orbit with implants. So we used to have stacking of Medpore implants, or we used to have Medpore with bone cement on top of it. And very often we found implants which were misplaced, and half of the implant used to be hanging in sinus. But now our concepts are much more clear. We know that the implant has to be placed at the posterior ledge, that is a stable bone posterior to any fracture. And we know that the buttresses, which are the pillars of the orbit, these are the buttresses vertical and horizontal, which need to be reconstructed. And we should do the rim of the orbit first and then the walls. So these concepts have helped us improvise in our results. We are now boldly taking up reconstructions like naso-orbitoethmoid fractures, zygomatic fractures. Oculoplastic surgeons have been able to do it very comfortably. Diplopia correction knowledge has now improved, and we are able to take up soft tissues and lacrimal drainage system abnormalities at the same time during our bony reconstructions. The additional new thing that we are doing now is we are also giving periocular micro and nano fat injections to augment the orbital wall, to augment the periocular volume. And we also look into the wound modulations with 5-fluorouracil, Botox, as well as steroids. Now, I think advancement in technology is tremendous in orbital trauma reconstruction. Virtually all the patients who have a complex trauma, we make 3D skull models. We also have access to virtual planning, intraoperative navigation, and now patient-specific implants are being manufactured by Indian companies. So these are the kind of 3D skull models that we create for most of our patients. We can explain to the patient the plan of the surgery, and also it's a good teaching tool for research academies. And we also pre-contour implants on these skull models and use these implants intraoperatively. Now, an advancement in this is that we use mirrored skull models. That is, we mirror the normal orbit onto the abnormal orbit, and we contour implants on this mirrored model, and that acts as a guide during surgery. Of course, virtual planning access is now available. Most of the multi-specialty hospitals have CMS software, and we can mirror the normal orbit onto the abnormal orbit and also virtually insert the implant that we want to use and see if that implant is adequate in size. So preoperatively itself, we come to know if the implant is inadequate, and we can plan a patient-specific implant for those patients. So this is how a patient-specific implant is done. That is, here I'm sitting at a Zoom meeting with the manufacturer. You explain to them exactly the area of coverage, what are the fixation points that you want, what is the mesh size and the thickness and everything, and you can customize an implant for the patient. Now the cost is also reduced because now Indian companies are manufacturing quite good implants. And this is one such customized implant where we have split the implant into smaller components for ease of insertion. And of course, during surgery now we have virtual guidance with navigation so that we can verify the implant position. This is what I'm doing. I'm running the navigation pointer on the implant and seeing whether it is symmetrized with the other side by using the mirrored image. Now I'll take you through a few of the cases, like this patient who has an enophthalmos. He already has a zygoma repair. You can see the zygoma is posterior. He also has a floor and medial wall fracture. This usually happens when other specialty people do orbits because they're scared to go posterior orbit. And so they just do the rim and come out, and the patient has residual enophthalmos. So here we have used navigation. We have, you can see the implant is resting on the posterior ledge. This is what I was explaining. And even the posterior cuts has the implant in position. And we reconstructed even the curvatures of the walls of the orbit. And you can see that the post-op result is extremely satisfactory. Similarly, another young man who has had surgery previously, he has residual enophthalmos. His zygoma is not in place, and you can see this blowout fracture here. The floor has been left behind. We have used navigation and also pre-contoured implants on a mirrored skull model. And this is the post-op symmetry that you can achieve with kind of technology that I'm talking about. So here, this is the patient post-operatively, and you can see enophthalmos is corrected beautifully if you take care of the curvatures as well as the volume of the orbit. Now, another patient with very severe comminuted fracture, he also has acute dacocystitis. We planned a DCR along with bony reconstruction. You can see how smashed the zygoma is as well as the anterior maxilla. Now, these are the cases where patient-specific implants are ideal. This patient was not affording one, and therefore we have done a reconstruction without a PSI. So what we do is we create osteotomies on the zygoma in 3 places and move the zygoma to its desired location. And the defect in the infromedial area of the infraorbital rim, we use a bone graft. Nowadays, we use ramus bone graft from the mandible because the face is already opened with a vestibular incision. And so ramus bone grafts are easy to harvest. So, and we are able to use sphenozygomatic area for plating because we have technology available. We are very close to the middle cranial fossa, but we are able to plate at that location also. So this is the bone graft being used for the inframedial rim, and the rest of the zygoma has been moved anteriorly and superiorly. And once the rim is in place, we do the walls. So here the mesh is placed and it is being fixated. And we are using navigation to see if the implant is symmetrized. So at the end of the procedure, we do a post-duction test to make sure that there is no impingement of the soft tissue in the implant. And then I also do a mid-face lift so that there is no sagging and we don't have eyelid problems post-operatively. But I tell you, in spite of all this, since these are young patients, we have to fight fibrosis, and post-operative wound modulation is needed in most of these patients. Now, post-operatively, you can see that the implant is in position, but it is inadequate. It is not covering the defect fully because the patient was not willing for patient-specific implant, and this is the biggest size of ready-made implants available. So this is one very good indication of customized implant. Post-operatively, you can see that his enophthalmos is corrected well, but he has this bony deformity because there is the zygomatic bone is deformed, and therefore that we cannot correct without an onlay implant. Now, another patient with a very severe orbital fracture, he also has lost his eye. He has thusical eye with ptosis and telecanthus. Now here I do the bony and soft tissue reconstruction together. You may ask me why in a non-seeing eye you need to do so much. Because if you just put a prosthesis, it will look like this because the socket is not in the normal position. You need to do the bony reconstruction first for these patients. Here we have used pre-contoured implant, done the bony reconstruction as well as his ptosis correction, and we have given him a prosthetic eye with good post-op result. Now, if there is volume deficit, in spite of all this, you can use a ball implant for these patients. Now, another patient with very severe enophthalmos, he has virtually no floor medial wall. So we have customized an implant, and you can see the size of implant that this patient needed. This cannot be available in the pre-existing implants which are available with the companies. And post-operatively, you can see the symmetry that we are able to achieve. And his enophthalmos is corrected beautifully. We had more than 8 or 9 millimeter of enophthalmos and also hypoglobus. He has some eyelid abnormalities which will need secondary correction. Now, another patient who is using a prosthetic eye, you can see that the entire socket is moved downwards and there is asymmetry. So this, I like to reiterate the point that these patients need bony reconstruction. Although that eye is non-seeing, but they need that extra confidence by improved cosmesis. And you need to do the bony reconstruction, which is a very elaborate procedure. This patient needed a customized implant. We have fixed that. And also I have done some amount of his eyelid correction. And you can see the socket is now gone back to its normal position and he looks good with his eyeglasses. Now we have gone ahead in technology in orbital reconstruction. We are able to use microscopes and therefore we can do 3D surgery. And of course, we can't do very big reconstructions when there is a lot of movement of the bones, but still 3D surgery is a good advancement. And I like to show you this new mixed reality viewer that BrainLab has now developed. This is a very interesting concept wherein you can get the entire 3D anatomy of the patient in air. So in the room, you can get this entire 3D anatomy. Here there is a tumor and you can discuss it with the patient, which is being done here. And also you can discuss with your colleagues the plan of action for the particular patient. And you can get this 3D model even intraoperatively. So now we are getting navigation that is real-time guidance during surgery with the pre-op CT scan of the patients. But you will be able to get a 3D model in your OT with this kind of technology. And this is not a sci-fi movie. It is an actual reality. BrainLab has it. And this is where we are heading to in orbital trauma. So thank you very much for your kind attention. And I'd like to take any questions if there are any.
That was truly an amazing talk, Preeti, and took us to an entirely different world where I thought it was not ophthalmology you're doing, but something a lot more. And I've seen you from a very young age, and I really all admiration for the way you've evolved. But taking a very simple question, when would you intervene, Dr. Grover or anybody in the expert panel or even Preeti, when would you intervene when there's an orbital fracture? Would you wait for the edema to settle, or would you want to do it as a primary step?
Yes, in acute trauma, we like to wait for at least 7 to 10 days for the edema to subside. But if you obviously see a muscle entrapment, which is tight, then I think you can intervene earlier, because you don't want the muscle to go in for necrosis. But most of the time in adults, the muscle is only prolapsed in the fractured area, but it's not tightly impinged. So in those cases, it's a good idea to wait for 7 to 10 days before taking up the case.
Whereas in children, would you differ?
Yeah, so in children, usually these are green stick injuries where the muscle is very tightly impinged in the fractured fragment, and they can also have oculocardiac reflex and bradycardia. So they are actually emergencies, and we like to take them up as soon as possible.
Yeah. Yes, Dr. Shreya.
Yeah, it was wonderful, extremely well talk, and really, as Dr. Chitra ma'am said, it was a different world. Nowadays people are doing navigation technology and everything is available. But my question to either Dr. Grover sir, Dr. Honavar sir, or Dr. Preeti, whatever, whosoever answer, if person doesn't have facility of this modern technology, and if you don't have any setup in your operation theater, 1 or 2 practical tips for the ophthalmologist, for oculoplastic surgeon who don't have this navigation technology, how would you go for that? And how would you select the specific implant for this person? And what practical point you will keep in your mind while putting an implant?
I think navigation surgery is only for complex surgeries, no? For all simple.
That's right. So
I
for
think,
what?
Yes, Dr. Grover.
as Preeti explained, these are the technologies that are very useful for complex fractures, multiple wall fractures, fractures which have been repaired before and did not align well. So you have those complex situations where the 3D imaging, the modeling, where the patient-specific implants are particularly important. But 80 to 90% of our cases can be managed with the conventional techniques, most often using titanium preformed piece implants, or even mid-core and smaller ones, or even absorbable ones in the green stick type of fractures which Preeti spoke about. So those are the cases where you can just bridge across the fracture, or make sure in the larger ones, which particularly those where there is a floor and medial wall fracture, that you have an adequate titanium implant with a medial extension, which can be placed in the right position with the right angulation to restore the volume in most cases. So it's not necessary to have all these tools, but for complex cases, wherever you have difficulties with the conventional techniques, now you have the tools to be able to manage them.
And
excellent talk, Preeti.
yes, yes.
And,
And Dr. Preeti,
everything
how would you
was
titrate?
adequately.
How would you titrate the dose of nanofat you are injecting for fat atrophy?
So if you're using micro or nano fat, then I don't overfill it at all, because the retention is quite high. And it's always good to undercorrect than to overfill, because it's so unpredictable. But that is only in delayed cases, only when there is secondary reconstructions and you don't have any other options for soft tissue reconstruction. We fill little bit so that the periocular area can camouflage a small amount of ophthalmos that is there. And answering your first question as to what are the tips, now actually most of our cases we are able to do without navigation, because we are using mirrored skull models. They are quite cheap. They're about 4,000 or 6,000 rupees. And if you contour the implants on a mirrored model, then you're able to use that implant intraoperatively, and you know for sure that your reconstruction will be then symmetrical with the other side, because you're using a mirrored model to recontour. So that's a very good tool now. And I have, the last few cases, I have done only pre-contouring on mirrored models and found the result to be almost similar to use of navigation. But navigation is available in multi-specialties. Actually,
Yeah,
only
that's
if
all.
you look for it, you will find it. Most of the big hospitals have it. And they also have the CMF
Yes.
software, which is not being used because it's only the neurosurgeons who are using it. And if you ask for it, it will be there.
Thank you very
Thank-
much, Dr. Preeti. We shall now, I think, Dr. Ashish, you're ready. So we can take your talk, and I'd like to introduce Dr. Ashish Nagpal, who's the medical director and the chief eye surgeon at Nagpal Center for Cornea, Ahmedabad, and he's going to take us on to a very quintessential topic, principles of corneal wound suturing. So on to you, Dr. Ashish.
Thank you so much, ma'am. And thank you for including me in this very lovely session with such robust speakers and teachers, my own teachers here. I hope I'm audible, and
Yes,
can you
yes.
see my slides?
Yes.
Okay. So in the next 8 minutes, I'll just cover the basic principles of corneal wound suturing. I think they come in all varieties and all types and all depths. But just to highlight, what we need is just a basic idea of what are we trying to achieve. We all know that we've already covered glaucoma. We just want to restore the anatomy and the function and prevent other complications. So how do we go about doing it? So I've divided into 3 parts as what to do before surgery, during, and after. Before and after, I'll be limiting to just a few busy slides just to cover all the points. But an important point here is that one should spend time to understand the nature of the injury, try and talk to the patient's relatives to understand, because sometimes there may be projectiles which may not be understood, especially with children. And second is, do not use any topical drops because the eye is open and we may impact the internal structures, and never forcefully examine. I would say we should always try and examine under controlled conditions. And of course, we can do all the tests, the CT scan, B scan, but I'll move over to the other important aspects is because normally the issue is also about when to do the surgery right away. Sometimes it's not possible. So just a few tips that we should have a patch, but best with the occluder with something so that it covers the globe. It does not put any pressure on the eye, because if the structures may come outside. Another important thing is to give an analgesic and anti-emetic so that there is least amount of pressure, because in such sort of injuries, the patients may also be pretty traumatized and there may be a lot of anxiety and other aspects. And of course, tetanus, of course, can be covered as well. Avoid pressure patch is the message. And the most important thing is usually in these cases, I find that the pre-surgery, when the patient is under anesthesia, when you're taking the patient for surgery, is when you should spend time to try and understand, because a slit lamp examination sometimes is not possible in these situations. So one should spend time just before the surgery, before you scrub, to have a look, understand the kind of injury and what all it will require. And during surgery, so once you are taking the patient, once you're ready, I think the most important thing I feel is to make sure that you have the right kind of speculum, or you can use lid sutures, because we do not want any pressure at all on the globe. And the second part is that we should totally avoid, not totally avoid, because sometimes it's very difficult to put an offsite, and you may actually, there may be some adnexal injury which you may like to treat, and it's very difficult to do that. So a lot of times we can do away without this, or maybe a modified offsite without the adhesive. And as you start, the first thing is, after you have examined, you need to do a thorough wash of the wound margin as atraumatically as possible, clear all the debris, look for any foreign bodies, making sure that you do not introduce any foreign body inside, which may be, and be very gentle, try and avoid pulling on any structures, or because sometimes it is, nature tries to heal it very well with the iris, and fibrinous membrane is very difficult to differentiate. So try and use BSS and visco as much as possible to differentiate between the two. And once you've established how big is the corneal tear, how big is the wound, then you can introduce you can definitely use a side port, because that is the best way. Do not try and introduce viscoelastic or BSS or air from the main wound per se. Although there may be, having said that, there may be times when there is no other option because it's a very soft tie, but you have to try and balance these situations. And of course, just a note here that whenever you finished with the surgery, you always suture up the side port as well. So what are the types of wound? This is just to cover broadly that you may have wounds which are perpendicular, they may be shelved, they may be areas which may be involving the limbus, and sometimes you also get an idea of whether the person will need a vitrectomy or a lens management as well. So these are the broad types of the wounds. So how do we go about treating them? I will be briefly covering it in the next 5 minutes. So before we start suturing them, I think the important thing is to keep in mind the type of needle and the type of suture. Most commonly, we'll be using 10-0 nylon. And I personally prefer to use the CS Ultima needle because it's very sharp, and although the Orolab needle is also pretty good, there's no financial interest here, but these are the two needles which I would prefer for any corneal trauma. The reason is because in these situations, we also would like to use a no-touch technique wherever possible, so that you do not have to lift up the edge of the wound, and you need a very sharp and spatulated needle which can pass through easily. Moreover, with this particular needle, it also helps because it becomes like a triangular spatulated entry. It eases in the burial of the knot as well, which I'll be discussing towards the end of my talk. So I think there is no compromise to the quality of instruments. Just note that we would need a non-locking needle holder in these situations, because sometimes if it gets locked, sometimes you may pull on the tissue. So it's always recommended to use a non-locking needle holder. And of course, you can use forceps. You should have both atraumatic forceps and tooth forceps, depending on the, so that you can use them accordingly. So this is just a mnemonic to remember, just to remember the principles that what are we trying to achieve? We need very good apposition because the cornea is not a very elastic tissue like skin. So we need to have a good apposition on table, and it has to be good enough that we do not make it too tight or too loose. The length, the general recommendation is it should be equidistant from the posterior margin. Why I'll be discussing in the next slide, because sometimes the wounds may not be very perpendicular. So I'll describe why we should look at the posterior margin. And the tension also needs to be appropriate because of the curvature of the cornea. So the recommendation is to have a little tighter tension, especially when the cornea is edematous, because sometimes it may become loose later on. And of course, it should be tighter in the periphery versus the center. The radiality, the basic principle is to be perpendicular to the tear, as we know. So this is an ideal dimension of a suture, that it should be of this much 1.5 length. It should be at least 90% for any corneal suturing and equal on both sides and perpendicular to the wound. But this is also for mainly surgical wounds. But in a tear, you may have a variety of suturing. Like in this case, this fortunately was a lamellar tear. It was not a full thickness tear. So in this case, you can get away with a 70 to 80% thickness. You do not actually need to go so deep. So why I was describing the posterior edge, why it should be equidistant to the posterior edge, is because most of these cases, a lot of them will have a shell wound. And if you try to make it equidistant to the anterior, you can see in the slide below that it will be inappropriate traction, and the posterior edge will be gaping over there, and it will lead to inappropriate tissue apposition, which you can see. This is an OCT of one of our patients before surgery. As you can see, the posterior edge is unopposed. So we had to resuture it, and then we opposed it again. And that's how, so this is just to show you that this is how well opposed the tissue should be. And that's why we need to keep the posterior edge. Sometimes it's not visible, so sometimes you have to estimate it, but this is the basic principle that you should oppose it to the posterior edge. So this is the the same picture as you can see over here. Coming to the entry angle, I think this is an important thing to remember, that suppose how you are entering the needle. So if it is at an acute angle, sometimes you will end up with a very shallow suture. If you are doing a very obtuse angle, so you need to keep this in mind. The idea is to go perpendicular to the cornea. So you may have to shift your needle holder and hand accordingly. Sometimes you may, if it's difficult, you can shift your microscope also into different positions and take it. You do not need to sit superiorly or temporally, depending on your comfort. So this is just to highlight that what happens if you have a shallow suture, you will have inappropriate, as already seen, unequal depth will lead to an overriding of the tissue. Full thickness suture, you may end up, there's a risk of microbial invasion and contamination. So as always, we avoid full thickness sutures in most surgeries in cornea. So the sequence of suturing is something which everybody has to figure out after looking at the particular. So this is a small animation made by my colleague, Dr. Yatri Pandya, in which you can see, so you identify the apex. So first suture the apex, and then you can suture the ends, and then titrate and suture accordingly, take more sutures based on the length of the tear. If you have a limbal incision, limbal tear, you can go from there. If you have a odd, sometimes you may need to start from the other end. And sometimes you may need to take a temporary suture, because if it's collapsing, you can take a suture at the apex and take a broad suture and then try and put some visco and start again. But these are just general guidelines. You will have to figure it out as you go. And why it is important about the number of sutures, I think I'll quickly go through these principles. These are busy slides, but I think these are there in most textbooks and YouTube as well. So you can go through them, but it's very important why the length of the suture, why each suture would be important, because you have to understand the zone of compression. And so accordingly, one needs to titrate and take more number of sutures. So this particular slide is to highlight what we should not do, because in this case, there are less sutures and you can see there is more scarring and a lot of overriding. So one has to take more sutures in this kind of a situation. So that needs to be titrated, and one needs to understand the zone of compression and accordingly take. And most important, I think, is I see a lot of sutures when the knots are not buried, and it undoes a very good surgery as well. So I think it's very important to bury the knot, rotate it, and try and place it away from the visual axis is the recommendation. And once you've rotated it, just pull it back again so that it's easier to remove, because the V shape of the knot goes towards the apex of the cornea. These are just techniques which are recommended since many years, that the basic principles of that you should take tighter sutures and longer sutures in the periphery, with the idea that you maintain the contour of the cornea. But sometimes, depending on the tissue loss, one may need to modify. So the globe integrity is more important, but if you have a clean tear, a clean knife, then these principles will work very well. I will not go into the details of the topographic considerations. I've just kept them here in case somebody needs to refer to them in the slide. And this concludes what are the principles. I think towards the end, what to do, I have just covered the systemic antibiotics, topical steroids. And of course, one would need suture removal and follow-up management, either for the cataract. Sometimes patients may end up with trichomes or endophthalmitis. I think Dr. Sushmita probably will be covering that part. And with this, I conclude my talk with these principles. Thank you very much.
Excellent basic principle. What you explained, Dr. Ashish, was very, very, very well explained. My question to you is, how would you manage that tri-radiate wound, which has got no linear cuts? So what should we keep in our mind? Because most of the patient, we don't get that even V-cut linear wound. They may have just a stone injury, and you'll have a tri-radiate or four-radiate wound. And any other surgical principle or surgical modalities you are using, Dr. Purendran, when you are doing corneal tear repair?
I think Dr. Ashish has covered very nicely and highlighted the important aspects. And in 8 minutes time, I think he has covered most of the things. And he has highlighted few things which are often neglected, like what we have to do before the surgery. And I think that points, all those points are very, very useful. And as you have said, the tri-radiate tear, what we do is in such cases we go for all the branches of the tri-radiate tear we repair, and then in the middle we put up a string suture, and if needed we can use a glue and do the glue BCL also at the end, and all these cases for better apposition and no leak things. But all these cases are really, it depends on many things, like the extent of tear, the size of tear, how much tethering is there, how many pieces of the corneal this thing are there, because these wounds are very, very lacerated wounds and are very, very this thing patient specific, and all the strategies have to be developed on table during this thing. So what another thing I would like to say is that our ultimate goal is to have a watertight wound. It should not leak from anywhere. So glue BCL is at the end should be it helps a lot, and very little amount of glue, if it is required, then we can place and form the chamber with air.
My signal network had gone, so just a question. I missed out some of the discussions here.
Yeah.
What would be your timing of suture removal if you have done your sutures? Based on between Dr. Maskati, would you want to take this?
Yeah, it depends on the age of the patient. The younger the child, if you have, first of all, when you're doing a repair in a child, you need to tell the parents about multiple GA, that they will require multiple GA, because a child will heal even about 10 days or 15 days time. Sometimes in very young children, you can remove the sutures when it is healed. Generally speaking, you look for a thin gray scar, gray white line. If you get, then you know that the wound is healed well. And if your apposition is good, then usually in about 30 to 45 days, you can remove it even in adults. But you need to watch it on slit lamp, check it out. And then in children, I've removed even in 10 or 15 days.
Would you remove what would be an interval between
days
removing?
Time, sometimes in very young children, you can remove the sutures when it is healed. Generally speaking, you look for a thin gray scar, gray white line. If you get, then you know that the wound is healed well. And if your apposition is good, then usually in about 30 to 45 days, you can remove it even in adults. But you need to watch it on slit lamp, check it out. And why was my voice repeated? I have no idea.
I don't know. I have no idea. This was so.
I was very impressed. The first time that ARC has given me double speech.
If it's a very linear wound, also, would you think of doing interrupted sutures, or is there any role of continuous suturing anywhere? Or
absolutely none. Only interrupted sutures, and you can remove, if you're not sure, you can remove alternate sutures. Don't remove all at the same time. Remove alternate sutures, wait and watch. Maybe 4 or 5 days later, you can go in and remove the remaining.
And
while we are talking on sutures, I thought I might just take a question on a PK or a DALK graft in general, which is not a traumatic suturing, which might have a lot of relevance because this topic is corneal suturing. So in this, what would be your measure of removing your sutures? Yes, you would leave an interval of a month and all that. But to what level of astigmatism would you want to remove the sutures, or would you want to remove all of them?
In a PK or a DALK, it just depends on your suturing technique. So if you've taken continuous or interrupted, or if you've taken interrupted, then you can decide according to the astigmatism. You can start playing around. You can loosen or tighten sutures, or you can, if they're continuous sutures, you can loosen or tighten. If they are interrupted sutures, you can remove key sutures and reduce the astigmatism. I normally start all this about in adults in about 30 days or so.
Dr. Ashish, if it is a very irregular cornea, when you're talking again about a graft,
Okay.
what would be, which suture would you think is a critical suture to remove? How would you take your decision?
I mean, I'm assuming that we are removing it because of the high astigmatism
Astigmatism,
irregularity.
Yes.
Okay. So what suture I would try and base it on the topography, but sometimes if it is, and of course the steeper one, which matches with the steepest axis. But I'm very slow with this. I think with the grafts, I'm very slow. I'm very careful. I also gauge the patient's needs and requirements. Because I usually do counsel them that it's very various. Sometimes you may feel that that is the suture to remove and it suddenly the astigmatism goes on the other side. So the two things, the important thing is topography and also looking at the graft host junction. The compactness of the graft host junction tells me that it has healed. And if there are any striae also matching with the tight suture, then I would go for that removal.
Yeah, and anybody, oh, sorry, ma'am.
Yes, go ahead, Shreya.
Yeah.
Just
Anybody with the experience of using viscoelastic or AC maintainer while repairing corneal tear, which helps? Dr. Maskati, I think you are using viscoelastics.
I use a lot of viscoelastic. It gives me comfort, but at the end, as Purendra correctly said, I'm extremely fond of air. So I will put in air at the end of any traumatic corneal tear that I'm suturing.
And what is your experience of using AC maintainer while suturing?
I don't use AC maintainers. Yeah.
Anybody from the panel, are they using?
Not for suture.
Okay.
Can I just add one point, ma'am?
Yes.
So this regarding the graft host junction healing, what Maskati sir and Dr. Ashish were discussing, I just want to add one point is that nowadays we have the anterior segment OCT. So that is also a very useful tool to study the opposition of the graft host junction, whether it is whether it's opposed properly or it's just superficially opposed and things like that. So that could also help in timing of suture removal. So you could monitor that, and based on that also you can time a suture removal.
Yeah. Any other questions, or shall I go on to the next speaker?
Yeah, I just wanted to add again something which Ashish, because of paucity of time, couldn't cover, is that if the corneal tear extends up to the limbus, it is mandatory to open conjunctiva near the limbus and look for a scleral tear, an extension. So if a corneal, if it looks all fine, but if the limbus is involved, you must open the conjunctiva there. And if there is a scleral tear, you need to close the limbus first and then keep following the tear down, and you can use even vicryl sutures to close the sclera, and then come back to the cornea and finish the corneal suturing.
Yes, a very relevant point. Yes. Thank you very much, Dr. Maskati and Dr. Naspal. We shall now go on to our next speaker, Dr. Sushmita Shah, who's a cornea and refractive consultant from iLife Khar and Netra Mandir, and she's going to be showing us some different kind of case scenarios which on corneal trauma. On to you, Dr. Sushmita.
Good evening, everyone. I thank Chitra ma'am, Shreya ma'am, and the esteemed ARC for this opportunity. So moving on from these brilliant didactic talks which my previous speakers have presented, I will be presenting a few case situations which describe the unique sequelae that you may come across following cornea and ocular surface in trauma. So my first case is this 13-year-old child who presented to us sometime around 2013 with history of Lyme injury about 2 weeks before. Now, as you can see, there is a dense deposition of calcituna in the cornea, and there is extensive loss of the ocular surface epithelium involving the tarsal surface, the bulbar surface, the corneal surface, etc. So what we did was we excised the Lyme deposits in the superior part of the cornea and replaced it with a lamellar patch graft, not a full thickness graft, but a patch graft, and covered the entire surface with amniotic membrane. Now, this is post-op about 5.5 months. We can see limbal stem cell deficiency and with some amount of symblepharon. But even at this point, she had about 6/60 vision. Unfortunately, she was lost to follow-up after this and came back more than a year later with a visual acuity of 6/60 with symblepharon with an obvious limbal stem cell deficiency. So we planned a simple limbal epithelial transplantation or the SLET procedure along with the conjunctival autograft for the symblepharon. As you are aware, the SLET is now the treatment of choice for all eyes with unilateral limbal stem cell deficiency. And this is the post-op follow-up after the SLET. As you can see, the limbal biopsy well in place, and there's a bandage contact lens. Unfortunately, we again lost follow-up of this child 3 months post the SLET procedure, when she presented to us 6 years later with again a best-corrected visual acuity of 6/60, partial LSCD, symblepharon, both superiorly and inferiorly. So to rehabilitate her, we planned symblepharon release with amniotic membrane grafting, conjunctival autografting, and an anterior lamellar keratoplasty. So because of the symblepharon, we are unable to put the speculum. So we put lid sutures and retracted the lids. This is the inferior symblepharon, which we are currently excising. And this is the upper lid. We have excised the superior symblepharon. This is the undersurface of the upper lid. This is fibrin glue being put on the tarsal surface, and we are fixing an amniotic membrane there. Now we take a conjunctival autograph from the bulbar conjunctiva involving the nasal part of the eye. And as we know, the symblepharon has to be replaced with the conjunctival autograft. If you just put an amniotic membrane, it does not work. So putting the conjunctival autograft in the superior bulbar conjunctiva. The inferior symblepharon is covered with the conjunctival autograft also from the bulbar surface. Now this is the bare surface of the sclera, which is being covered from where we took the graft. We are covering it with the amniotic membrane. Next is the anterior lamellar keratoplasty. We're trying to put the dissector, and we thought maybe we might be able to induce a bubble, but because of the patch graft, pre-existing patch graft which was there, the bubble never happened. So we are going ahead and doing a lamellar dissection of the corneal tissue. So it's not really possible to do a DALC and expose the complete descemet membrane, but we could always go to the pre-descemetic space, and therefore we planned this anterolamellar keratoplasty. This is the patch graft, which is now currently being excised. And that's the donor corneal tissue, which is from which the descemet and the endothelium has been removed. And now we are doing 16 sutures, and we have secured the graft. This is the post-op 6 months. Now our visual acuity has improved to 6/18 N6 with a clear graft and a very well maintained ocular surface. Both fornices were well formed except for a small symblepharon in the inferior fornix. The anterior segment OCT is extremely interesting here. As you can see, the crystal clear stroma, and there is a very nice epithelium that you can see. So this essentially indicates the establishment of the limbus in spite of such severe chemical injury, and we can see a mild amount of corneal tissue still there on top of the descemet membrane, which again points that this was not a deep anterolamellar keratoplasty, but an anterolamellar keratoplasty. And the surface, as you can see, even with the fluorescent staining, it is very well maintained. So this kind of concludes as a successful outcome in this severe chemical injury. So limbal stem cell deficiency, or which is also the LSCD, and abnormal ocular surface are known sequelae of the chemical injuries, and we may often need multiple stage procedures to obtain a stable ocular surface and provide visual rehabilitation to the patients. Dr. Maskati sir is covering the chemical injury, shall not go in details of this. Move on to the next situation. This was a young 32-year-old male who was referred to us with complaints of a white spot in his right eye of 2 months duration. He had an unaided visual acuity of 6/6 N6. And on slit lamp evaluation, we found a wide cystic lesion near the 11 o'clock limbus with conjunctival override. And the lesion contained whitish fluid, which was found to be pre-descemetic in location on the anterior segment OCT. Looking at his past history, which was, we retrieved his past records and found that he had presented earlier with a history of trauma about 6 months back. And he had a lamellar corneal tear, which was extending from the limbus at 11 o'clock with an foreign body impacted within the lips of the corneal tear. The foreign body was removed and he was treated with topical antibiotics. No surgical intervention was done. Hence, we came to the diagnosis that this was a traumatic intracorneal epithelial cyst. And the management option here was very tricky, as the patient had an uncorrected visual acuity of 6/6 and 6, but he was concerned about the look of that white spot in his eye. And also there was a possibility of this cyst increasing in size and coming into the visual acuity, in which case it could have caused scarring and loss of vision. So we had to plan something which is minimally invasive and to remove the cyst. Also, simple aspiration of the cyst is known to cause recurrences. So the other options include aspiration of the cyst contents along with cauterization of the cyst using either 96% ethanol or 20% trichloroacetic acid. The other options include excision and drainage, which would have been very invasive. Keratoplasty is usually reserved for recurrent cases and is also a very invasive technique. So we planned a cyst aspiration with chemical cauterization using ethanol under local anesthesia. Then we came across literature which mentions that single application of ethanol can cause recurrence of the cyst. So we planned multiple applications of ethanol within the same sitting. So here is the video. So the localized conjunctival peritomy is done to look for any occult scleral tear. We debride the corneal epithelium with a 15 number blade. Now that's the pre-existing corneal tear. It has been identified. A 26 gauge needle, 30 gauge needle is inserted and the cyst contents are aspirated out. Then this is 96% ethanol is injected into the cyst cavity and it is kept for 1 minute. At the end of 1 minute, it is replaced with distilled water and the process is repeated thrice. The tear is then sutured using 10-0 nylon sutures. And sutures are buried. So this is the post-op follow-up. The top left picture was the early post-op. As you can see, a resolving cyst even noted also on the anterior segment OCT. The right photograph is the late post-op. We have now more than almost 36 months follow-up. He has a small refractive error of 0.5 cylinder at 90 degrees, but he is maintaining at 6/6 and 6, and we still don't have any recurrence. So penetrating or perforating corneal tears may lead to implantation of epithelial cells deep into the corneal stroma, especially if it is located at the limbus. These cells may proliferate to give rise to intercorneal epithelial cysts. Leaving lamellar tears unsutured may lead to increased chances of such complications, and therefore lamellar tears should be sutured. Ashish has also highlighted that point beautifully. Intracorneal epithelial cysts may be effectively managed in a minimally invasive way by cauterization with 96% ethanol, followed by distilled water, leading to attenuation of cyst and no recurrence. What we did differently here was 3 applications of ethanol instead of 1 to prevent recurrence. Coming to my last case, this was a 36-year-old male factory worker who was referred to us with complaints of decreased vision and glare. Now he had suffered a corneal tear while working about 8 months back, and my referring colleague had done a very good corneal tear repair along with an iris abscission. And thereafter, a suture removal was also done. Now, when he presented to us, his uncorrected visual acuity was just counting finger 3 meters, and his best corrected visual acuity with a refractive error of plus 2.50 and -8 diopter cylinder at 9 degrees. His vision was improving to 6/9 parts and N6, and he was 6/6 and 6 in the other eye, and he refused to wear glasses. And on slit lamp examination, as you can see in the photograph, there was a healed, there was a sutured corneal tear with an underlying iris defect. So these are the topography. As you can see, very steep cornea, overlying the area where the scar is, and the anterior segment OCT. Here again, you can see very nicely a post-corneal wound by my referring colleague, and how nicely the both edges of the cornea are well opposed. Now, this patient vehemently refused a contact lens trial. So he wanted a surgical management of his problem. So we planned an iridoplasty using the modified Sixer knot, followed by a topography guided PRK and mitomycin C under topical anesthesia. This is the video of the modified Sixer knot. This is a different case, not this case. So what we do is we made a side port entry, inject pilocarpine, constrict the pupil, then inject viscoelastic. And this is a 9-O-proline suture, which is passed through the torn edges of the iris, and it is taken out through the cornea. And it's to be very clear in eyes which are phakic that the swage of the needle does not touch the anterior lens capsule. You can do it much more comfortably if it is a phakic or a pseudophakic eye. Now the equivalent hook is introduced, the suture is pulled out to make a loop, and we have the trailing edge of the suture pass through the loop 3 times. And then we pull both ends of the suture to oppose the knot. The same thing is repeated 3 times to make a knot, which is in a 3-2-1 fashion. And then this was followed about 6 weeks later by topography guided PRK. As I had mentioned, he had a refractive error of plus 2.5 with a -8 diopter cylinder. The machine can correct only up to -6. So that is what we corrected. And an ablation depth of around 158 micron was done. And the residual bed thickness was about more than 352 microns. So this is the final follow-up photograph. This is about 3 months. We can see a much more regularized topography. And the iris defect has also been sutured, so he has no symptoms of glare also, and his uncorrected visual acuity now is 6/12 N6, and he's pretty happy and rehabilitated. So to summarize, anterior segment reconstruction and visual rehabilitation may still remain a challenge following a good primary repair of corneal wounds, and contact lens as well as laser vision correction may be an effective modality. Thank you so much.
Oh, that they were very diverse, wonderful cases and very impressive. And I request Dr. Quresh Muscati and Ashish to discuss the first two cases.
Yeah, excellent work. Both the cases brought out a lot of take-home message, and Sushmita gave all those take-home messages.
Yeah.
So there are many ways to skin a cat, and all these have to be tackled on an individual basis because all traumas are different. No one trauma is like the second trauma, but all excellently done, Sushmita.
Thank you, sir.
Any point for discussion, Dr. Ashish? Dr. Ashish, are you there?
No.
I got disconnected.
Yeah.
No.
Did you
The last
watch?
one.
Oh, you couldn't watch her cases?
No, I missed them. I missed it.
Oh, okay, Dr. Shreya, you have anything to ask? Dr. Quresh can answer and Sushmita can.
Nothing. No, I don't have to ask anything. I think I just wanted to ask Dr. Sushmita, other than this topic, do you have any experience of tin and patch graft using for trauma cases?
Patch graft. No, ma'am, I have not used it for any trauma cases as of now. It is usually for perforations and melt, but I presume like what Purendra sir was also mentioning, sometimes in this tri-radiate tear, when you have if you have a small area where you are not able to seal it, tin and patch graft might be an option if you do not have a cyanoacrylate handy in your OR. A very small bit of tinons might be good. Tinons, it gets integrated very beautifully with the cornea. Now I've recently published on paper also on that of where we had to put a tinon and do a penetrating keratoplasty after that. And when we evaluated the corneal button, we found how beautifully the tinon can integrate into the corneal stroma. So I think it's a good idea if you do not have cyanoacrylate and you have a wound which is still leaking and you're not able to close it in spite of a lot of sutures, then possibly yes.
Thank you. Any question, Dr. Muscati? If you
No, I'm fine. Yeah.
Yeah.
Dr. Ashish? Okay. Thank you.
Thank you. Thank you, Sushmita. Very interesting cases, all of them.
Thank you, ma'am.
Yeah, we shall now go on to our next speaker, Dr. Quresh Muscati, who heads the Muscati Eye Clinic, is our past president and an amazing person who has taken Corneal Society of our country to a very different level from long immemorial. So he is going to talk to us on a very interesting topic, chemical burns, which could throw up a lot of controversies. On to you, Doctor.
Thank you. Yeah. Am I visible?
Yes, yes. No, your screen
Slides are not visible.
Slides are not visible.
Slides are not visible.
Okay.
You are more important than your slides.
Oh, no, your slides are important
One
too.
sec. I need to go to enable screen share.
Yes.
Where is that?
That green button, Mr. Sunil, are you there? Could you
Sir,
guide him?
yes, sir. Actually, are you on a Mac, sir?
I'm on a regular laptop.
So with the on the Zoom window, the bottom 6 o'clock, there is a green button which says share screen.
Have you opened up your presentation already?
Yeah, my presentation is open.
Yeah, on the Zoom window, just click the green button.
There's no 1 minute. It says more. Yeah,
No.
now it says share screen. Yeah.
Yes. The pop-up will come, just click the blue button.
Okay. Hopefully you should be. You
Yeah.
got my.
Yes, we are able to see your presentation.
Is it full screen? Now? Is it
No,
full
it's
screen?
not slide. Yeah, now.
Is it
Yes.
full screen?
Yes, yes.
Okay.
Yes.
So we'll quickly go through the modern approach to chemical injury. For paucity of time, we'll talk mainly about acute injuries. We'll go straight to Dua's classification because we've had various classifications. We were all using the Thoft classification and others. But now, once we know about limbal stem cells, we are now using mainly the Dua classification, which was first published, I think, in 2001. So it's about 20 years old. And this is a dynamic classification. So every time we are dealing with the chemical burns, we can classify it as grade 2 or grade 3 or whatever. And with treatment, it might change. It might from 3, it might go to 1, or from 3, it might go to 5. So every time we see the patient, we need to change the classification depending on what we are observing. So that's something to be kept in mind. The prognosis we give is as per the classification. If it is grade 5 or 6, we need to be very guarded in our prognosis. And hopefully, if it's from grade 1 to about grade 3, we are able to restore fairly good vision. Emergency treatment, I'm just stressing a few points. Copious lavage means you need the resident or the eye surgeon concerned to wash the eye for 1 to 2 hours. It is not copious lavage, doesn't mean instead of 10 cc syringe, we use 2 10 cc syringes. So there has to be tremendous amount of lavage or wash because the chemicals tend to stick around over there. And if you see physical, if it's lime, you might see physical lime particles there. You need to remove all of them. You need to double evert and find them and remove them because lime being left behind, we've seen in patients coming after 3 months with still lime in the fornix. So you need to remove this. And if there is necrotic dead material, you need to remove that because the more dead material you have there, the more polymorphonucleoside invasion. So you need to remove all dead material. It's not helping in any way. So if atropine is a must, every patient must receive a drop of atropine with chemical burns. There's no homatropine, there's no cyclopentolate. These are all homeopathic medicines. Topical antibiotics in every case. And I'm extremely fond of 10% vitamin C or ascorbate. Again, there is no dilution involved. If you get injection vitamin C, it is already a 10% solution. Just have to break the ampule, put it in an empty eye drop bottle and dispense. If you don't get injection vitamin C in your area, just take tablet vitamin C, which is 500 milligram, dissolve it in 5 cc of saline, and you can distribute, or 5 cc of distilled water also is fine. 5 cc of some lubricant is also fine. So there's no dilution involved. Again, since the 80s, since I was a resident, we've been using patient's own venous blood, and I'll explain why. So we take the patient's blood from the elbow. venous blood and inject it subconjunctivally into the upper and lower fornices as it is seen over here. And if the patient is admitted, if you are in a hospital setup, then at night I pour drop by drop blood on the patient's cornea till a blood clot forms, and then gently close the eyelid at night so as not to dislodge the clot. And in the morning, you can start medicine again. What about steroids? People keep on asking me in chemical burns, sir, how can we use steroids? Of course, you must use steroids. Please understand, if there is no infection, again, I reiterate, if there is no infection, steroids are not contraindicated. There is Kenyon et al. Had proved very well in animal experiments that epithelial mitosis and epithelial sliding to cover a defect takes place better if the underlying stroma is treated with steroids, so that there is the edema is reduced. So steroids in all cases, of course, if there is a melt or an impending melt, or if there is infection, you will not use it. So I told you about the blood clots as well. What about amniotic membrane? Again, we should be proud that a landmark paper of almost 22 years ago by late Dr. M.H. Sridhar and Dr. Rao and Sangwan et al. Conclusively proved for the first time to the world that amniotic membrane, which is always used for late chronic chemical burns, can and should be used in acute chemical burns also. After you've cleaned and removed all the necrotic material, it has a very big anti-inflammatory role. Amniotic membrane in a cold case may remain for even 2 months in the eye, but here an amniotic membrane in a hot case like this, in an acute injury, may get absorbed in a few days to a week, but it will tamp down the inflammation quite remarkably. So again, this is something that all of us must use. Systemic treatment is the usual. I won't dwell into the details. Sedatives if the patient is in a lot of pain, and ascorbic acid or vitamin C by mouth or intravenously can be given at least 2 grams per day, should be given for at least a month. Why am I stressing so much on vitamin C? Because it reduces the incidence of ulcers and perforations. How does it do it? It's required by fibroblasts to make collagen. So this is not a new finding. This is from in the AIOS at ARVO. It has been shown time and again. Right from 76 onwards, there have been papers. I dug out some of the papers. And so vitamin C, which is so cheap, so easily available, and so little used in chemical burns, I request all of you to make it part of our armamentarium. Why am I talking about blood? Blood is a buffer. It dilutes the chemicals. It separates tissues. It's a fibrinolytic. It prevents symblepharon formation. So it has multiple uses of the blood. It contains anti-proteases, which inhibits collagenase. As you know, the young collagen, which is being, the surface is trying to repair and form collagen, it is broken down by collagenase. So if you have some anti-proteases and anti-collagenase, it will destroy the collagenase and help the enzymes, help the collagen to grow. And the platelets, which change their shape completely, and they become pseudopodal, and they develop pseudopods like amoebae, and they hold on to the collagen like the dog and cat that you see there, and prevent it from being broken down, and they fill up all the gaps in the denuded surface. There are newer treatment modalities. Doxycycline is something which all corneal surgeons love because it reduces melt. So it should be given in every chemical burns as well. And we talked a little about the lovely role of tenons to reduce ischemia. You can do a tenoplasty. That means take it along with blood vessels and bring it to the area so that it brings blood vessels in at the same time. Some new therapies from chiefly from Iran that they have come. And again, this has been there since about 10 years now, where simple oxygen, we are familiar with use of oxygen during our COVID pandemic that we had. So I urge you, those of you who are in a hospital setup, to use oxygen. It is such a simple thing with such dramatic results in chemical burns. And they used this for, they divided patients with grade 3 and 4 injuries. Half of them received oxygen, half of them did not. And the oxygen group showed increased corneal transparency, decreased vascularization, better visual acuity. And all it needs is a simple mask. So just like you have been giving in COVID, a simple mask with a flow rate of just 10 liters per minute for an hour twice a day. If the patient is hospitalized, a simple mask oxygen 1 hour twice a day is sufficient, and there is dramatic results. A visual rehabilitation stage, as I said, due to positive time, we won't talk about it, but stem cell transplants are the way to go in a chronic case. And as Sushmita said, SLET is what we all use after learning from Dr. Sangwan. In fact, I can't even believe that it is just about 6 or 7 years old that he taught us this, because it seems that we've been doing it for such a long time. If SLET cannot be done with bilateral, there are other regimes, CLET and COMET as well. So this is Dr. Sangwan's series, which he presented in the AAO. I can't better that with my own pictures, so I'm just showing you his and the remarkable results that he got in 125 cases. Thank you for your attention. Sorry if I've overloaded your brain with too much information and caused you to remain awake. But the good news is that I have actually finished. Thank you so much.
Thank
Thank you so much, Dr. Maskati. I was truly unlucky to hear your talk because of a very bad network issue at my end. So maybe my questions are going to be sort of irrelevant to what you spoke. But I'll just ask one basic question before I ask Shreya to take on. When would you consider an AMG in an early chemical injury?
Sorry.
I don't know whether it's covered.
When would you
consider using
amniotic membrane graft?
Oh, amniotic membrane. Yes, of course. I would consider it almost every patient of chemical injury, except the grade 1, grade 2 patients, where you know that you're going to get a good result with the other treatments.
Yeah.
But otherwise, there's absolutely no harm if you can clean up the tissue and patient is willing to come into the theater. Not all patients are willing to come into the theater, but I would definitely use this, and I'm finding that it really reduces the inflammation quite a bit. Sometimes I've used it even twice. 10 days later, I've put it again.
Dr. Ashish, there's some controversy on this, right? About using AMG? Now, the latest.
Yeah, I think there are two schools of thought. One is, shall I speak?
Yes, yes.
Yes.
I think there are two schools of thought. One is because AMG shows such fantastic results, and
Yes,
it probably
yes.
is the only thing which we can easily procure and do in chemical injuries. That it has a low threshold for most people. But having said that, I think there are certain injuries, especially acid injuries, and even minor alkali injuries or thermal injuries. If you like, I would like to see them in 2 days, start the steroids, do the lavage, and see the epithelialization. If they don't have much of a conjunctival damage, some of them may heal, as Dr. Maskari pointed out. Sometimes they may go from grade 3 to grade 1 within 2 days or 3 days,
Yes.
especially children. So I think that is what we kind of keep in mind based on the situation. I think, Sushmita, any points to add?
I think, yeah, even I'd agree with what Ashish said. Even my threshold for amniotic membrane grafting is pretty low. And because what we have seen clinically is, even if with the steroids and other things, the surface inflammation subsides and the surface epithelializes, when in subsequently, say after 6 months, when you're trying to do the SLET, we find that in eyes where we had done a AMG, we can very beautifully peel off all the pannus and symphyron and do the SLET very well. The underlying tissue is much less scarred. So versus those eyes in which we've only treated with steroids and maybe not done an amniotic membrane, there is a lot of scarring. We have a lot of problem in dissecting the pannus, resulting in a very rough underlying surface. And of course, the SLET outcomes also are marginally, not as good as those eyes where an amniotic membrane had been done in the primary stage. So I very strongly recommend an amniotic membrane. Anything more than grade 2 injuries, I usually
Can you please mute yourself, everybody? Please mute yourself so that we don't get background noise. We should all be realizing that. Yes, good answers. I mean, we have two types of two considerations. Yes, Dr. Shakeen. Yes, Dr. Shakeen. Yes.
Good evening, Dr. Ma'am Chitra. I'm sorry I was late to join. One point I just want to ask Dr. Krish about conformer and BCL to be given immediately after this first aid of a chemical burn to avoid simulacrum. What do you say about this?
Yes, again, if you're putting in an amniotic membrane, we find the incidence of simulacrum is reduced, but absolutely no harm. I'm very fond of both the ring conformers as well as the large conformers to prevent simulacrum. And when the patient is not close to you and you're not going to see the patient often enough, putting in a ring conformer or a full conformer is a safety valve that you have.
Yes.
Thank you.
Yes, Dr. Shreya?
The conformer question I was going to ask already answered by Dr. Maskati. And if it is at all not healing it, so what is your experience of PK for this chemical burn, penetrating kinetoplasty?
Not in the acute phase. Whatever it is,
Yeah,
you wait,
but what is your experience?
sometimes you're pleasantly surprised. And at the end of it, if you're evaluating the patient for you need to evaluate whether you really need to do a PK. Nowadays, with our preference for DALC, our incidence of doing PK has gone down. So if there has been no perforation of the cornea, no melts, and then you assume that the endothelium is okay. And as Sushmita is fond of, do an OCT and check everything. I would go for a DALC if I have to, but I would prefer first to do SNET and stabilize the surface. And then if I have to, I would do a DALC rather than a PK.
I think I just
Yes, Doctor.
I'll just make one point here that in tuna injuries, sometimes the deposits are very deep. So I think, as Dr. Maskari pointed out, I think in those cases, you are almost doing a very deep dissection to remove as much as possible. So in those dissections, you should have a backup tissue, because sometimes you may, so that those are the only times when we may kind of think of a therapeutic PK, generally speaking, not as a planned approach in acute stage.
Yes.
Could I just one point
Sorry.
regarding the role of tarsorrhaphy in some of these cases where nothing else is helping in healing. Sometimes a little lowly tarsorrhaphy helps in a good deal of healing. What do you feel about that?
Yes, absolutely agree, sir. Yeah, we have had cases wherein patients have come with perforation, so there is no there's no choice but to do a penetrating keratoplasty. But having said that, we know when the limbus is completely damaged because of the chemical, the graft is not going to survive. So we do a PK. It's more of a tectonic keratoplasty, and we close the lids with the tarsorrhaphy. Sometimes we even do a central tarsorrhaphy and close the lid. We expect the surface inflammation to heal, and and then maybe after a year or so we can open up the entire surface, release all the simulacrum, and then do a surface reconstruction with limbal biopsy, with the limbal graft and conjunctival autograft and things like that. But yes, tarsorrhaphy is, I think, priceless in these situations to avoid exposure, avoid melt, etc. It's very good point, sir.
The trophic element.
Yes, sir.
Yes. So thank you. We shall now go on to our next speaker, Dr. Urmila, who's Urmila Chawla is again a very, very, very important person in Haryana Ophthalmic Society. Heads the Ocular Plasty Department of the Postgraduate Institute of Medical Sciences at PGIMS Rohtak. Today eye is concerned, and that is lacrimal apparatus injuries. On to you, Dr. Urmila. I do hope Dr. Santosh is connected now, and Dr. Parihar, we could take questions from them. Could you share your screen, Dr. Urmila?
Urmil, you are muted.
Dr. Urmil, you are muted.
Oh, sorry, ma'am. Sorry. How do you go behind? Okay.
At the outset, I would like to thank Dr. Chitra ma'am and Dr. Shreya ma'am for giving me this opportunity. And moving ahead from orbital and corneal trauma, let's go to lacrimal apparatus injuries. That covers my topic. So lacrimal apparatus, as we know, consists of the secretory part and the drainage part. The secretory part mainly comprises of the glands, and the drainage part consists of the lacrimal sac, just a sec, can I? Just a sec, I'm facing a bit problem with the speaker view. Okay, so the drainage part consists of the lacrimal puncta, the canaliculi, sac, and the nasolacrimal duct. Whenever we speak of lacrimal apparatus injuries, it per se means mainly the drainage part, which is more involved, and the frequency of trauma being more related to the canaliculus maximum, the lower canaliculus, the upper, and can be bicanalicular. The nasolacrimal duct, the sac, and the lacrimal puncta follow. So since we know that these cases are generally polytrauma cases, we need a team approach following the life support care system, the site support care, functional care, and the cosmetic care. Following this, wherever we need imaging as well as medico-legal and photographic documentation, especially in oculoplasty cases, is a must nowadays. Lacrimal trauma comprises almost 16% of all eyelid injuries. Canalicular involvement comprises 81% cases, that's the maximum. The SAC and the NLD involvement involves 19% of cases. Damage to the drainage system can present with telecanthus, globe displacement, epiphora, and obstructive dactylocystitis. The consequences of epiphora may be in 10% of cases constant or nearly constant epiphora, in 40% cases symptomatic epiphora with ocular irritation, and 50% may be fairly asymptomatic in case one of the canaliculus is functioning and is not injured. So lacrimal trauma basically has both functional and cosmetic effect, and so needs to be stressed upon. More common in males, and mean age range is 14 to 30 years, and lower canaliculus involvement is maximum 50 to 75%. Modes of trauma could be direct laceration or blunt trauma. Direct laceration, mainly the penetrating wound. Dog bite injury is quite common. Traction to the lateral canthus may lead to displacements of the medial canthal tendon, leading to the canalicular tear. Cattle care is one other means of trauma. And by blunt trauma, we can have fist or airbag injury. Dog bite injuries being very common, one should always remember that whenever a patient presents to us, copious irrigation of the wound is a must, along with the anti-rabies prophylaxis should be taken care of. And the previous school of thought was that dog bite injuries should be repaired later on after a gap, but nowadays primary repair is considered to be important. Canalicular injuries then can be occult or obvious. Occult in the form of a simple linear tear, but on exploration they come out to be having a deep canalicular tear, or the obvious ones where there can be avulsion of the lid. High index of suspicion is required in all cases of eyelid or medial canthal injuries. Any lid laceration medial to the punctum should be suspected to involve the canalicular system unless proved otherwise, so one needs to be cautious. Timing of surgery, ideally, it should be an early primary repair within 24 to 48 hours. However, if infection and edema are the contraindicating factors, you can wait for 3-4 days, and most cases are successful if repaired within 5 days. 80% of the drainage is through the lower canaliculi. So the more emphasis is on the repair of lower canaliculi. So some previous school of thought was that if upper canalicular injury is there, it can be left as to resolve on its own if the lower canaliculi is functioning. But however, most authors now believe that all canalicular lacerations should be repaired. Now, since medial canthal area, the tendon is in close proximity with the canaliculi, it is also known to get injured very soon along with the canaliculi. So the thorough examination of the area is a must. By doing a traction test, grasping the edge of the lower and the upper eyelid laterally and pulling it, normally we have that bowstring or the taut appearance in the medial MPL area. But if that is absent, it gives an indication of the canthal injury. Repair of the posterior crest of MCT is critical because that leads to the main apposition of the punctum to the globe and helps in the drainage. So that is more critical, and it can be repaired with 4-0 double arm Prolene, and complete avulsion. If it is there, then microplating may be needed. Canalicular repair, if done in a stepwise approach, would be giving us gratifying results, and beginning with the identifying the cut ends, then passing the stent for the anastomosis, the pericanalicular tissue suturing, and the eyelid margin repair are the most important things to be done. Basic requirements in a good OT and optimal illumination and magnification are a must, with good set of lacrimal instruments and a skilled surgeon. Coming to the localizing the cut ends of the canaliculus, the proximal cut end is easy to be located. On inspection, it can be seen on magnification, and a Bowman's probe pass from the punctum will really reveal it. However, the distal torn end is the one which is difficult to be searched. The lighter color of the canaliculus is contrasted with the surroundings, and that is what it is seen. But it is easier said than done. It is difficult to be located sometimes in the mess. This is a calamary sign which is seen where there's a distal end is seen as a collagenous white ring around the blood-stained area around. However, with beginners, or if in case you are not able to inspect it, you can localize with other ways of fluid irrigation, the fluorescent stained fluid, viscoelastic, trypan blue dye, and the air bubble, the Morrison's technique, and you can locate the distal end of the torn punctum. Now, once you have inspected, the second step comes the anastomosis of these two ends, for which we do the canalization of the canalicular system. The monocanalicular stents are the most commonly used, mini-Manoka stent being the most common. In this, only one the torn canaliculus or the injured canaliculus is stented. The mini-Manoka stent has a collarate present. It is self-retaining with a silicone tube. It is inert and stable, and it is easily retrievable also, can be kept for 2 to 3 months. But however, the limitation being its cost. So in case in your OT, you are left with no other option, you don't have the mini-Manoka or you don't have other stents, you can go with easily with the IV catheter that is almost present in all OTs. The 22 gauge size is the ideal one that can be used. Be careful to cut the front tip, the sharp end of the cannula, and then you can go ahead with the normal stenting of the single torn canaliculus. It has an advantage over only one advantage over the mini-Manoka stent, that it is stiff. So it helps in more easy penetration of the anatomical location of the punctums. However, it is not that inert, so reactions can be there and can't be kept for a longer time. The second option is the annular stents. The bicanalicular intubation can be done with the annular stents in 2 ways. One is when we are only intubating the 2 canaliculi with the pigtail probe. The pigtail probe it should be round, atraumatic, and eyed, which is now easily available. It is passed through the intact canaliculus, curves through the common canaliculus, and comes out through the torn canaliculus. This is a small video showing the pigtail probe. We are passing it through the normal upper canaliculus. It comes out through the torn distal end of the punctum. Through the eye, we are threading the Prolene suture, and this Prolene suture is further threaded over the silicone tube. Once it has been threaded over the silicone tube, it is taken out simply from the upper canaliculus, and then the stent comes out. Now we pass it again through the distal cut end, and again we thread it and take it out. So in this way, both the ends can be there opposed to it. However, the only, so this is the end result of a pigtail probe cannulation. We can see it over here. Only the problem is that in 10% cases, it can be traumatic to the canaliculus. And also in 10% cases where common canaliculus is not present, this pigtail probe cannot be used. And so it has to be given away, but it has not become so popular because of the trauma it might cause, but people are still using it. We have other bicanalicular stents also, the Crawford stent and the Ritling stent. In this, we are not only intubating the upper and the lower canaliculus, but we are going through the lacrimal drainage system into the nasal cavity. These bicanalicular stents are good for when both the upper and the lower canaliculus are injured. And moreover, when the drawback can be that they may cause damage to the nasal cavity or the Hasner valve. However, they are used often whenever both the canaliculi are injured. We should keep in mind the complications of these stents, the cheese wiring, which is more common with the bicanalicular stents if there is tightening, ocular irritation, infection, irritation more with the monocanalicular ones, inflammation, granuloma, and prolapse also more with the monocanalicular stents. Once we are through with the stenting, the third step comes of pericanalicular suturing. 3 equally spaced 80 vital sutures can be used through the pericanalicular tissue, the posterior pericanalicular, the anterior pericanalicular, and through the gray line, which gives good apposition. And once we approximate the edges, the silicone tubing also has to be tightened again. And in case the MPL is involved, a non-absorbable suture has to be passed to it. Fixation suture has to be passed to the MPL, and we go ahead with the complete of the suturing. The last step is completing the lid margin, where 2 interrupted 6-0 sutures are placed in a vertical mattress fashion. And in case you have used an IV cannula catheter for stenting, you need to secure it separately with the lid margin away from the cornea. This shows the canaliculus. This is the tear that has occurred with the proximal end is seen with the probe, and in the anatomical position, we pass the probe. Once you have dilated it, you pass the mini-Manoka stent. Comes out, and when it comes out from the other end, you pull it and make sure that you snuggle the collet at this time only with the punctum because it becomes later difficult later on. And this is the calamary ring that is visible, and you pass your stent through the ring, and once you have passed, you just double check it once, and you start with your pericanalicular suturing. The 6-0 vital sutures pass through for the posterior pericanalicular area, and they are approximated. Once you approximate, there will be a tenting of the this Manoka stent. You again snugly fit it. You complete your pericanalicular suturing, and once you've completed your pericanalicular suturing, the stent would be well in place, tightened. And after you complete this suturing, you can go ahead with your you use the 6-0 silk suture to pass through mattress suture to pass through the lid margin, and lid margin apposition is attained after this, and you complete your rest of the suturing. The rest of the tear skin suturing is completed, and you finish with this completion of this marginal tear. So after this, we remember that success rate with canalicular repair, if followed with the steps, it is 20 to 100%. However, it can be risen to 86 to 95% in routine cases if we do an early and microscopic reanastomosis with silicone intubation. Delayed repair and dog bite injuries have poor results, and simple stepwise approach will give you gratifying results. Lastly, coming to the distal lacrimal drainage system, the SAC and the NLD, because they are well protected by bony structures, the incidence of trauma is less. However, in naso-orbitoethmoid fractures, these are known to occur in the form of bony involvement when the bony NLD canal is fractured, or it can be the soft tissue involvement. We need a definite facial CT scan to see the extent of fracture and direct injury to the lacrimal sac, palpation of the area to see the degree of instability, and principles of primary repair. We need to repair it one stage, exposure of all fracture fragments, precise anatomic rigid fixation, immediate bone grafting, definite soft tissue management. And once this has been done, in the later stage, if NLD blockage is still there, reassess at 3 months post-injury. CT and DCG would be helpful, and DCR should be done preferably 6 months post-injury. Coming to the chemical injury to the lacrimal area, these can be immediate effects, early effects, and late effects. Like in cornea, the lacrimal area has its own effect. Punctal area, the punctal laceration, skin burns, then punctal occlusion and canalicular strictures can be there. If the canalicular system trauma is there, wash thoroughly, but never do syringing, because that way you will be pushing the chemical into the nasal cavity. Probing with bicanalicular intubation, conjunctivo DCR, and these are the options. If NLD and lacrimal sac trauma is there and puncta is normal, you can go ahead with probing with bicanalicular intubation. However, if the puncta is involved, a later stage intracath DCR is the option you have. So the take-home message I would give: be always suspicious and do a careful inspection of the wound area always. Repair try within 48 hours. Intubation with silicone stent to prevent stenosis while the laceration is healing is quite important. And early meticulous primary restoration of the anatomy is the key to success. Thank you so much.
That was a wonderful talk, Dr. Urmil, and so thorough and so complete. And actually, I even tried to teach us people who have no connection to the subspecialty. Dr. Santosh, something very basic I'm going to ask you. What are the clinical signs which will indicate canthal involvement? And what are the clinical signs which will indicate that there could be an adnexal injury also?
Okay, canthal involvement generally when there is unilateral telecanthus, when the distance between the midline and the medial canthus is increased on the ipsilateral side, then there is bound to be canthal injury. Second is the traction test that you do. The medial canthal tendon, if it is attached, there will not be any movement of the medial tissue of the eyelid, but whereas if freely moves or if it partially moves, then obviously the medial canthal tendon may be avulsed. Or the medial most injury of the eyelid, medial avulsion of the eyelid also indicates that there could be a canthal tear.
Yeah, and when would you suspect whether there's also an orbital fracture at the same time?
Okay, orbital fracture at the same time if there is crepitus in that area, or if there is any nasal bleeding accompanying the injury. In such situations, you should suspect a medial orbital fracture, and ocular motility restriction obviously indicates that there is medial rectus tethering in the fracture. So in such situations, if at all the patient experiences nasal bleeding, or if the nasal bridge is flat, or if there is ocular motility restriction, then I would get a quick CT scan done before I would repair the injury.
Dr. Shreya?
Yeah, I'd like to ask question. Urmil, it was very nice presentation, wonderful presentation. Dr. Honavar, I would like to ask you, am I audible?
Yeah.
Yes.
Yeah. I would like to ask you, what about the secondary stricture happened if it is not repaired? And what are the points you would take? What are the points we should take keep in our mind while repairing primarily, not to happen the secondary stricture?
Well, primarily, if you have intubation already, that too with a reliable intubation such as monocanalicular or bicanalicular intubation, and not use a IV cannula, then the chance of recanalization is as high as 80 to 90%. If at all there is stricture, that could be because of the sutures that you pass in the pericanalicular area may have cheese wired through. That is the reason why it may heal by secondary intention, and wherever canaliculus heals by secondary intention around the tube, there is a possibility of stricture. Second reason for stricture is early removal of the intubation set, either because the patient pulls it by himself or herself, or you remove it earlier than 3 months. 3 months is supposed to be ideal. So if you remove earlier than that, there could be a secondary stricture. So that is how I would prevent a secondary stricture. But if at all it happens, you can always refresh the wound on either sides of the stricture and re-intubate and resuture.
Thank you. Paucity of time, we need to move on, but that was a wonderful talk, Dr. Urmil.
Dr.
We shall
Grover
now
may
go
have a
on to
point
Dr.
to add because he is too.
Dr. Grover. Yes, Dr.
I
Grover,
think
you have anything to add here?
you've covered everything very well, and so did Urmil with a wonderful video. So what is important is that earlier it was thought of as a very complex procedure. Increasingly, it is realized that it can be done very simply. You just need some good magnification and good illumination, because identification of the cut ends is the only difficulty in canalicular repair, the medial cut end. The more medial the cut, the more difficult it gets. So sometimes you may need to inject air from the opposite side in order to visualize the point of opening if it is a very medial cut. But working under a microscope, you realize that the canaliculus is much larger than what you thought, and it appears as a very white pearly thing which is easy to identify. And now there are some simple single stitch techniques also which have been described. Once you do a good stenting, as Santosh was emphasizing, the simpler techniques of apposition also work quite well. So you need not really consider it as a difficult procedure, and just carry out a simple repair. If you're able to identify the ends and do a good stenting, you'll succeed.
Can I add one point here? Can I add one point here? Actually, whenever you are not able to find out the distal end, we have designed one device, and that is a very good device based on the pigtail technique. So in that device, you are sure that you are finding out the distal end, and along with that, you have silicone tube which acts as a stand. So anytime anybody is interested, I'll just
please send one.
Yeah, thank you, sir. I'll share.
Thank you. We shall go on to our next speaker, Dr. Tennarson, who's a senior vitreoretina consultant from the Eye Foundation Group of Hospitals based at Coimbatore. And he's going to talk on, again, a very important topic, post-traumatic endophthalmitis. On to you, Dr. Tennarson.
Ma'am, I think good evening, everyone. I thank Yassi and Chitra ma'am for giving me this wonderful opportunity. So I'll be talking about post-traumatic endophthalmitis. So treatment 11.8% in case of open globe injuries without intraocular foreign body. It comprises almost around 50% cases of endophthalmitis. So this is a case of a old man who had a hair blast injury. He underwent pericorneal repair, perforation repair elsewhere, and presented 2 weeks later to us. He had a traumatic cataract with zonal paralysis post-repair, and the ultrasound shows severe vitreous with membrane loculations, and he was planned for postrenal lymphectomy with vitrectomy with intravitreal antibiotics. So this is the surgical video. These hooks were used to enlarge the pupil, following which 3 postrenal ports were inserted, and infusion is checked whether it is a chest cavity, following which postrenal mastectomy was done. And there was a dense vitreous
I think his net is.
Yes.
Doctor, the slide is
Tennyson, are you there? No, there is some
There
huge weather issues here.
So
Dr.
the slide
Tennyson?
is frozen.
No, I think he has had a network problem. Tennyson, could you may have to connect on your phone or change your network?
I think he's logged out now.
No. I think there's a terrific rainfall here.
We can just give.
Move to the next speaker. And then yeah, we go on. Tennyson, Tennyson is starting the screen. Yeah, we'll just give him one try.
I think I'll switch off my video. I think there is a poor network issue.
Yes.
So this was a case of the video of the patient. Iris hooks were used to catch the pupil, following which 3 pars plana ports were inserted, and pars plana infusion was checked, following which pars plana lensectomy was done. There was a dense vitreous accretion behind the lens with a vitreous hemorrhage sheet. It was cleared off. A space was created for the vitrectomy, and you can see there is a dense vitreous membranes along with the exudates posteriorly, and core vitrectomy was done. Once the core vitrectomy was done, the exudative layers were removed, and you can see the retina behind, and the thorough peripheral examination was done, base dissection was done. Infronasally, there was a localized retinal detachment. A suspicion of intraocular foreign body was made, and there was a foreign body which was embedded subretinally, which was retrieved out, and it was delivered out through the clear corneal incision, and it was brought out with the help of foreign body intravitreal forceps. And again, there was one more intravitreal foreign body, which was again noticed, which was embedded in the choroidal layer. The nature of foreign body is a stone. So again, you can see a second stone which is embedded in the choroid, which was again retrieved. It was brought out anteriorly through the clear corneal incision. And once it was done, the retina was settled, fluid air exchange was done, endolaser was applied to the break, silicone oil injection was done, retina was settled, and intravitreal antibiotic injection was given. Patient is left aphakic. The best corrected visual acuity was 660 at the end. So what are all the clinical characteristics? Most often patient presents with severe pain. So how do you differentiate from the traumatic pain? Usually the traumatic endophthalmitis will have excruciating pain along with a purulent discharge, hypopyon, severe anterior chamber reaction, along with traumatic cataract, vitritis, and retinitis. This plays a crucial role. It should be done as early as possible within the next day of primary corneal or scleral perforation repair. You have to look for dense vitreous exudates or detachment, or in case of some foreign body, intraocular foreign body also has to be looked for. The other investigation modalities should be done. In cases of metallic injury, X-ray orbit AP lateral should be done. In other radiolucent or radiopaque capacities, computed CT scan should be done. At least less than 1.5 to 2 millimeter cut sizes should be done to rule out any intraocular foreign bodies. This is medico-legally very important. So Ocular Trauma Society severity, they have various scorings, which is based on the presenting visual acuity with other clinical features, based on which the outcome was prognosed. There are certain high risk and prognostic factors. So depending upon the mechanism of injury, if there is a penetration or perforation and rupture, and along with the intraocular foreign body, the chances of infection is very high and the prognosis is very bad. And the injury site, if it's a workplace and outdoor, the chances of mixed microbial microorganisms is very high. And again, the chances of infection and prognosis is bad. Depending upon the object which causes injury, if it is a contaminated vegetable matter or soil or wood, the chances of organism and the chances of traumatic endophthalmitis is very high, whereas in compared to the metallic objects. The zone of injury is very important. Zone 1, which is corneal and limbus, the direct entry of commensal organism is very high, and these type of injuries are more prone for traumatic endophthalmitis. Those who have lens capsule breach, vitreous prolapse, and uveal tissue prolapse have high chances of traumatic endophthalmitis. Associated retinal and choroidal detachment will have poor prognosis. The patients who presents late than 24 hours of injury to the hospital has high chances of traumatic endophthalmitis and poor prognosis. So this is a microbiological spectrum. Most commonly, gram-positive organism is seen post-trauma. Commensal organism, that is Staphylococcus epidermidis, is most common, whereas Bacillus cereus infection is very life-threatening. It has a very poor prognosis. Most often, they end up in enucleation or evisceration. Mixed microbial organism is a trend in traumatic endophthalmitis because of the modality of injury. So intraocular foreign body, it can directly cause mechanical injury. It can carry along with, it can cause a reaction. So the metallic foreign body, iron, copper, nickel, mercury can cause a toxic reaction, whereas vegetable mud, stone can cause infective reaction. Whereas gold, silver, and platinum are inert, and other non-metallic objects like glass, porcelain, rubber, can cause very minimal reaction. So how do we manage? Vitreous tap biopsy should be done along with intravitreal antibiotics should be given to cover both gram-positive and gram-negative. In case of suspicion of fungus, amphotericin B should be given. The systemic antibiotic plays very important role in cases of traumatic endophthalmitis compared to postoperative endophthalmitis. Here, in combination with intravitreal, it should be given at the time of repair as well as at the time of diagnosis of traumatic endophthalmitis. It helps in improving the prognosis. So vitrectomy plays a pivotal role. So early vitrectomy is the key. So for early vitrectomy, the diagnosis is very important. It is very challenging in cases of traumatic endophthalmitis because most of the patient will have corneal sutures. Media will be very hazy. There will be hyphema. There will be dense inflammatory membranes, traumatic cataract, and there might be retinal detachment along with it. So the advantage of vitrectomy is that it helps in reducing the inductive load. It helps in identifying the organism. It clears the media. It blocks the inflammatory chain. It treats a complication like retinal detachment. It helps in removing the intraocular foreign body. We can directly deliver the intravitreal antibiotics. The key point in vitrectomy is that avoid violent PVT induction. Aggressive peripheral vitrectomy should be avoided. Rapid suction should be avoided. So alternate intravitreal antibiotics like piperacillin, trazobactam should be considered in cases of Pseudomonas. In cases of Bacillus and Clostridium, clindamycin should be considered. In fungal, we have amphotericin and voricosol. So what are in traumatic endophthalmitis? Most often, patient will have associated retinal detachment, and after clearing the vitreous and settling the retina, silicone oil helps in settling the retina. And again, bacteria cannot multiply within the silicone oil. It provides a clear media as well. And in case of inadequate removal of vitreous, definitely silicone oil shouldn't be injected because it creates compartmentalization. So in conclude, post-traumatic endophthalmitis has worse visual prognosis compared to the post-operative endophthalmitis. The close monitoring of cases post-trauma and the early diagnosis and the treatment forms a key role in cases of management of post-traumatic endophthalmitis. Thank you.
Very nice talk, Dr. Tenarson. Two very basic questions I'll ask. So what would be the prediction of the final visual acuity in a post-traumatic endophthalmitis? And how would the location also decide?
Yes, most often the zone 1 injury has a high chances of traumatic endophthalmitis because it has a direct entry from the cornea, the commensal organisms, compared to the posterior zone 3. Whereas, as I showed in the thing, there are different parameters. The patient who had initial poor visual acuity, those who had a breach in the lens, those who had a zone 1 injury, and those who had traumatic retinal detachment along with it, and those who have Bacillus cereus infection. These are all the worst prognosis. These patients will have poor visual outcome.
Dr. Natarajan, I didn't know you had got connected again. Would you want to add anything at this for this question?
Visual prognosis will depend on the. Yeah, and can you hear me?
Yes, yes.
Yeah, no. The visual prognosis will depend on the point of injury, right? The center of cornea, the center of macula, and the optic nerve. But I think otherwise, if it is the endophthalmitis, again, depending on the virulent organism. If it is a bacillus, we have to really do it in an emergency. And maybe in hours, the eye can go, like the entire, all structures will, and we have to also change the
network is not good.
Infection. Oh.
The network is not right.
I think the prognosis. Can you hear? Clear? Okay, clear.
No.
Sorry.
Yeah, now we can hear you.
Okay. Can you hear?
Yeah.
No.
Yeah, yes, yes. We just
No,
give
I
you
think-
one try.
Yeah, no. So I think the endophthalmitis is the traumatic endophthalmitis prognosis is poor, and we have to really treat it aggressively. And in case sometimes you need antibiotic, intravitreal antibiotic, depending on if it is a fungal, antifungal, and if required, even silicone oil has to be injected.
Yes, yes. Thank you,
Yeah.
doctor. Yes, I think we
Ask the
have two more speakers and we need to do justice to them. So we shall go on to our next speaker, Dr. Shakeen Singh, who's a professor and head of Sri Guru Ram Das Institute of Medical Sciences and Research Center from Amritsar. And he is going to, actually is given 8 minutes to talk on a very extensive topic, sports and agricultural injuries. So he is going to essentially give us tips and guidelines.
He hosted
Good
a
evening once
wonderful,
again.
no, Dr. Shakeen Singh hosted a wonderful trauma conference in Amritsar in his medical college. Thank you, Shakeen.
Thank you, sir. Thank
Can
you
you
so
share?
much. Am I visible and audible, ma'am?
Yes, no, but your
Yes,
screen
sir.
is not seen.
Can anyone help me there?
Yeah, Mr. Sunil, could you help Dr. Shakeen to share his screen? Would you want Mr. Sunil, are you there?
Ma'am.
Mr. Sunil, could you maybe if it's taking time, then we would ask Dr. Mehul Shah to share his screen by the time Dr. Shakeen Singh screen gets set.
Yes, ma'am. Dr. Singh, do you need any help?
Yeah, I need your help. I'm on the MacBook.
Yeah, just open. Yeah. Dr. Mehul is
Dr.
started.
Mehul has, yes. Dr. Mehul is a medical director of the, I've already introduced him, Rashtriya Netralaya, and we look forward to a very important topic, pole-to-pole injuries. On to you, Dr. Mehul. Could you unmute yourself?
Unmute.
Okay. We have anterior and posterior segment divisions for all our clinical purposes, but trauma does not know the barrier. Trauma affects the multiple structure and it can create a lot of comorbidities which will prevent further improvement in the vision. So management can be done in single or multiple session by single or many stakeholders. Our database has got 20% eyes which have got more than 3 structures affected, and the number of structure affected has got significant impact on the visual outcome. So, as broadly we all know that as open globe injury, these are the implications of globe rupture penetrating intraocular foreign bodies. And there are many implications of the closed globe injury, which many things can happen, and all previous speakers has described very nicely. So I'll directly go to the case by case. If it is a closed globe contusion, there can be a very clear either lens damage or vitreous hemorrhage and traumatic retinal detachment. All these things, they can be tackled either in single sitting or multiple sitting. We'll not go to detail in that because they are very simple cases and anybody can handle it. But when we see the cases like this, there are phacocyl. These are cattle horn injury. We can see the bulge on superior limbus. And on exploring, we found out that the crystalline lens was there, and there was a zone 2 scleral rupture where vitrectomy was done, and patient was left aphakic initially, and then during second sitting we did the scleral fixated lens. This is another scenario where the injury is there, but patient was pseudophakic. We could see the PMMA lens broken. We found the broken haptic, lens removed. Anterior and posterior vitrectomy done. We found the retina was on and vitreous hemorrhage was removed. Following vitrectomy after 1 month, we did the scleral fixated lens. This is our indigenously designed lens named as a scleral tuck lens. That is without glue and without suture. And that is self-sustaining lens, which was done, and patient was doing extremely well, having 618 vision. This is another case which present with the catalon injury. When patient presented, it was a zone 3 injury, and it was quite a disintegrated anatomy. It was very difficult to understand how the injury was. When we tried to suture, we could see that the conjunctiva was there in the vitreous cavity. You could see the conjunctiva. Then we later on we found out the cut end of the sclera and sutured it. And after 2 weeks, we have taken patient for further intervention. After removal of hyphema, using entry chamber maintainer, the retina was found right into the entry segment. After bimanual dissection, the retina, which was very stiff, so this retina was mobilized. After removal of majority of the membranes, we injected PFCL. Initially, there was resistance, but then we could push the retina back. Then we did the endo laser and retina was settled. Patient has the finger counting vision, though the injury was very bad. So we were talking about post-trauma endophthalmitis. This was a girl, 7 years old, which presented to us with the injury following intravitreal injection. She had an OPL, and post-injection, we did the vitrectomy for her. We could completely clear the vitreous cavity. You can see the optic disc and fovea was all right. After completion of vitrectomy, Following 3 weeks, we have taken patient for scleral fixated lens. As we said, it is our indigenously designed lens, which is available in market also now, where it has got 2 flippers, which can be externalized through the scleral wound and covered by scleral flap. And that is a self-sustaining lens. So from no PL, this girl had a 612 vision at the end of 2 months. This is another endophthalmitis case when we are trying to explore and started doing vitrectomy, and in the vitreous cavity we found out the foreign body, and we could remove this foreign body. It was a whole bubble thorn in the eye, which was more than 2.5 centimeters. Unfortunately, this patient did not recover any visual acuity. And we utilized the 23 gauge endoscope in case of opaque media, and could settle many retinas. And later on, the keratoplasty was done. And there are other measures which we can use as temporary keratoprosthesis in case of opaque media. And during TKP plus PKP, in single sitting or separated sitting, endoscopic vitrectomy is very important, very good tool which will help you. Thank you. These are some cases I shared my experience regarding this.
Thank you very much. Dr. Shreya, would you want to take any question? Dr. Tennerson, would you like to ask any question in this particular case?
I don't. Yeah. Okay.
Yes, ma'am. Sir, how did you reposition the retina behind, which was in the anterior segment?
Dr. Mehul?
I'm not able to listen. Yeah.
The second case which you showed where retina was almost behind in the pupillary cavity, how did you reposition, sir? So, what was
That right. We did the bimanual dissection, removed all membranes, mobilized the retina, and then pushed it with the PFCL. So PFCL did the job for us. Once the retina was back, then we completed the vitrectomy, did the endolaser, injected oil, and then retina was settled. Functionality was poor. The vision was only 360.
okay.
Anything else, Dr. Shreya, you would like to ask before we go on to our last speaker? It's already quite late.
Yeah, it's late, so I'll not just ask the questions. We have questions, but we'll just give justice to the last.
We'll just talk about the endophthalmitis. We have a series of 114 endophthalmitis cases which is under publication, and we have tried to study the endophthalmitic vitrectomy study application in case of post-trauma endophthalmitis, and we found it very useful. All those findings of EVS, which was very late, which came during 90s, and those findings are applicable in post-operative cases. Those are applicable even in post-trauma cases. That's what I wanted to stress.
So what was the you have given systemic intravenous antibiotics?
No, it is all intravitreal versus immediate vitrectomy or a little late vitrectomy.
Yeah.
All cases needed vitrectomy.
Okay. You didn't give any adjuvant systemic antibiotics in any of the cases?
Systemic antibiotic as such also it did not have any role, but we have given antibiotic because of many of them were the polytrauma cases.
Okay.
They had some adnexal injuries and all, so we had to give the systemic antibiotic.
Thank you very much. We shall go on to the last speaker, Dr. Shakeen Singh. And yes, I had already introduced you, so we look forward to your presentation.
Is my slide visible there, ma'am?
Your slides are not visible.
I'm seeing on my screen, but I'm unable to.
Mr.
Can somebody
Sunil? Mr. Sunil, you couldn't help out?
Is it a laptop, sir?
It's a MacBook.
Mm.
If
Mr.
your
Sunil?
presentation is on, you can just minimize the presentation and reload again.
Mr. Sunil, are you there? Mr. Sunil? Some network issue.
By the time he is loading his presentation, I just wanted to ask Dr.
It's already, on the screen. I could see it, but I could not be able to bring it there.
Yeah, what? Hello.
Hello.
Yes, Mr. Sunil.
Sir,
Yes.
you've opened the presentation?
Yes, I opened the presentation.
On the Zoom window, there is a green button on the bottom which says share screen.
On the Zoom window.
Dr. Singh, the Zoom window. Sir, जितने सब दी फोटो आनी है ना थल्ले ग्रीन बटन है.
Just trying to see it. I lost it even. There's a no green.
Bottom पे green.
हाँ जी.
No, it's nowhere it's green.
Sir, जितने आप जी दी फोटो आ रही होगी, वीडियो आ रही होगी सब दी.
I'm not on that page.
So on the Zoom 6 o'clock, there is a green button.
Yes, yes. Click that.
There is CC. There is chat. There is action.
Sir, नहीं तो कीबोर्ड पे Alt S प्रेस कर दीजिए.
कीबोर्ड पे
Alt S. विंडो के ऊपर Alt S. S for शिमला.
चैट बटन के पास ग्रीन है. चैट के पास ग्रीन बटन है.
सब Alt S करेंगे तो एक पॉपअप आ जाएगा, उस पे ब्लू बटन होगा, वो क्लिक कर दीजिए.
Control, option, command.
Command S. If you are on a Mac, it would be all.
Command S. Yes.
तो पॉपअप आया होगा एक.
Yes.
ब्लू बटन नीचे राइट हैंड साइड पे शेयर, उसको क्लिक कर दीजिए.
Save.
No, save नहीं सर.
Or else, if you could send your presentation to Mr. Sunil, he can play and then you can speak. Is it okay?
Dr. Singh, either you can do a WhatsApp or a mail if you want.
Yeah, if you can send a WhatsApp to Mr. Sunil and he can just play the presentation.
We can move to the next one in the
By the time I just asked Dr. Natarajan sir, what is your experience with endoscopic guided vitrectomy for the trauma cases for endophthalmitis as well as any trauma?
Dr. Natarajan is not there. I think we could just take this question with Dr. Shakeen about agricultural injuries. Maybe it could be like in a case of a closed globe injury, where are the most common, rather Tennerson, would you want to take this question? In a case of a closed globe injury, what is the most common site of a retinal break?
Yes, ma'am. In the case of closed globe injury, blunt trauma, most common impact will be at inferior-temporal portion of the globe. So, as a coup and counter coup injury, the site of breaks would be at superior-nasal quadrant. The most common breaks will be superior-nasal dialysis and inferior-temporal retinal dialysis will be there.
Okay, right. And if there's a foreign body in case of a penetrating trauma in an like an agricultural injury, how would you manage it?
Generally, agricultural all vegetable matter will have fungal infections as most common. Otherwise, they will have a mixed microbial organisms. So we need to intervene as early as possible, and the prognosis is poor in such cases. So if it is a corneal infection, so definitely cornea has to be treated earlier. And if there is a fungal endophthalmitis, so it has to be operated along with an interventional amphotericin should be given.
Normal vegetative injury in our country which is found is because of bubble thorn injury. The name is Nilotica alessia, and there are n number of references, and we have published our articles that out of hundreds of cases, only 3% of this bubble thorn injury can have infection, because bubble thorn itself has got protective antifungal and antibacterial effect. We are not talking about other vegetative injury, but when there is injury because of penetrating injury because of bubble thorn, it can have a preventive effect for infection. And that article has been published in Indian Journal of Pharmacology. We have published that.
Yeah, I know. They are anecdotal cases. Dr. Sushmita, are you there?
I think.
Dr. Sushmita? Yeah. What are your thoughts about the role of temporary keratoprosthesis being used in a corneal injury?
Okay, so temporary keratoprosthesis is very useful when we have posterior segment pathology and which needs a surgical intervention, and we have a hazy cornea and you are not able to do the retina surgery because you cannot see through the hazy cornea. So what is typically done is that the cornea is trephined and the keratoprosthesis is secured. Usually we use vicryl sutures to secure the keratoprosthesis. And then once we get a good, watertight globe, the retina surgeon can go ahead and do the pars plana vitrectomy and whatever procedures are required to settle the retina and other things. And then the K-Pro is removed and is replaced with a graft with a full thickness penetrating keratoplasty. Now coming to the keratoprosthesis per se, there are 3 different sizes of keratoprosthesis available. Usually it is the 6.2, 7.2 and 8.2 sizes available. So what is typically done, usually the 8.2 is most commonly used. So you trefine the cornea with an 8 millimeter trefine, put the keratoprosthesis with just about 2 millimeters, 0.2 millimeter more, and then you do the retinal surgery and you remove the keratoprosthesis and replace it with a say 8.5 millimeter graft. So that's how the keratoprosthesis is done. There are 2 main types of keratoprosthesis: the Eckerd and the Lander's keratoprosthesis. The most commonly used is the Lander's keratoprosthesis, and what I mentioned, the sizes are what are the Lander's keratoprosthesis. So they give you very good globe, airtight, watertight globe, so that you can go ahead and do a combined procedures, and then you can replace the K-Pro and put a graft, full thickness graft.
Thank you very much, Dr. Sushmita. That was wonderful. That was one small part of the trauma thing which I wanted to also cover. But I think there have been some glitches right from the first time in the last 2.5 years. I had a network issue, and of course some of our speakers have also had small issues. But I think many of the topics were very well covered, and I truly want to thank the expert panel for contributing to each of the specific topics which were there in their domain. And thanks a lot to every dear speaker, right from Dr. Mayuri Kamar to Sushmita, to Dr. Urmil, to Dr. Mehul, to Dr. Tennerson, and everybody did a great justice to this session and even Dr. Bansal, Ashish Nagpal, everything was, and Dr. Maskati, everything was so relevant and so specific that even questions need not have been asked. And we could have moved from one talk to the other, and I'm truly thankful to you all. I need to also thank my ARC team for always having me behind me and supporting me through all my ventures. My special thanks are are due to my co-moderator, Dr. Shreya Shah, who actually put the topics together and brought the speakers together on this platform. And also my thanks are due to the AIOS admin led by Mr. Kripal and his very able team for the SMSs which they send and try to keep everybody updated about the webinar. My very special thanks to Sai and Manjula from Numerotech for connecting the entire country and reminding each and every one of our dear delegates about this particular meeting. My very special thanks are due to Mr. Sunil, as you can see, right from the beginning of the session or even half an hour earlier, how he tries valiantly to get us all to share our screen and get connected so that it's a smooth sequence of topics which are covered in this course of 2.5, 3 hours webinar. And finally, and most importantly, I deeply feel grateful and thankful to the entire Entode for sponsoring every single webinar of mine in the last 3 years, which has been a very good media of information transfer to the entire interested delegates, and I truly thank them. And I think the entire exercise would be incomplete if I do not thank our delegates, and it is their attendance, it's their joining in big numbers which actually eggs me on to come back with different flavors of webinars to keep the whole thing going, and so that we don't get repetitive either. And of course, finally, thank you all, dear speakers. Thanks to all, every single expert panel I've had right through the course of this meeting. Thanks a lot. Thank you.
Thank you so
Thank
much,
you so
ma'am.
much.
Thank you,
Thank you
Shreya.
so much,
Thank
ma'am.
you,
Thanks
everybody.
a
Good
lot
night.
for giving me this opportunity. Thank you
Thank you
so
so
much.
much.